And we will get started. Good morning. Welcome to the Joint Standing Committee on Health Coverage Insurance and Financial Services. We will be having some public hearings this morning, followed by lunch caucuses, followed by another public hearing or two, and then some work sessions, which we will in fact get to this afternoon. So that's our plan for the day. And we'll start with committee introductions, starting with Representative Evans.
Thank you, Madam Chair. My name is Richard Evans. I represent House District 120, including the towns of Atkinson, Brownville, Dover, Foxcroft, Medford, Milo, Arneville Township, and Lakeview Plantation.
Thank you, Representative Evans. Representative Arford.
Thank you, Madam Chair, and good morning. I am Poppy Arford. I represent District 49, the western part of Brunswick.
Representative Connor.
Thank you, Madam Chair. Good morning, everyone. My name is John Connor. I represent House District 58, which is part of Lewiston.
Representative Matheson.
Good morning, everybody. My name is Christy Matheson. I represent Kittery, District 1.
Representative Blyer.
Thank you, Madam Chair. Good morning to everyone. My name is Mark Blyer. I represent District 22, which is Leamington and part of Buxton, Standish, and Limerick.
Representative Melrano.
Good morning. My name is Gina Melrano. I represent House District 62, which is part of Auburn.
Representative Brooks.
Good morning. My name is Heidi Brooks, and I represent House District 61, which is part of Lewiston.
Representative Morris. You're on mute. There you go.
Yep. Good morning. I'm Representative Joshua Morris. I represent House District 75, which is Turner, Leeds, and Livermore.
Senator Brenner.
Thank you, Madam Chair. Good morning. My name is Stacy Brenner. I represent Senate District 30, which includes all of Gorham, most of Scarborough, and part of Buxton.
Thanks, Senator Brenner. And I'm Heather Sanborn, the Senate Chair of the committee, and I represent Senate District 28, which is half of Portland and half of Westbrook. We're joined today by Colleen McCarthy-Reed, our OPLA analyst, and Christian Ritchie, our clerk. I will also just note, because I had opportunity to watch some of our own hearing on YouTube yesterday, that when you see folks disappearing from the YouTube feed, they may still be here and still listening. If members of the committee turn off their camera for a moment, they appear to have left the meeting on the YouTube feed. But we here in the Zoom feed can still see that they're here and that they are often still listening, but had to turn off their camera for a moment. So I just wanted to mention that for the public who may be watching or joining us today. There may be more committee members listening than you can see in the YouTube stream. So with that out of the way, I will let folks know that we'll be using a 3-minute clock today. We have a very large lineup of folks to testify in our first hearing today, and I'm hopeful that we can move through it relatively quickly. Our committee has had a number of very long hearings over the last several days, and we've got a backlog of things to get to this afternoon as well. So that said, we will run a 3-minute clock, and we certainly invite you to be even more brief than that if the points that you are here to offer have already been said by those who have had opportunity to testify before you. The first bill that we'll hear today is LD 1196, presented by Representative Zager, and it is an act regarding targets for health plan investments in primary care and behavioral health. So we'll welcome Representative Zager into our meeting. I will also let the committee know that Representative Zager did send out a couple of graphs at my request so that they would be at the top of your email inbox this morning if you want to follow along. We did that in lieu of screen sharing, which I find a bit disruptive during a public hearing. So please go ahead and take a look at those while you're listening to Representative Zager. And with that said, Representative Zager, welcome, and please go ahead.
Thank you so much, Madam Chair, and rest of the committee. I recognize that you have a lot of work to do today. I will try to be brief. Senator Sanborn, let's see Representative Tepler here, but honorable other members of the HCIFS committee, I thank you so much for your service. I am indeed Sam Zager, I represent District 41 in Portland. Pleased to present this bill today. I thank the bipartisan, bicameral, rural to urban set of co-sponsors, including some members of this committee. This bill is designed to improve healthcare and make primary care and behavioral health more available. By doing so, we can decrease costs, which benefits us all. I have a patient I'll call Mike. He's around 60 years old, and unfortunately, he suffered a life-threatening cardiac event a few years ago. He received excellent care at a nearby hospital in Portland, and indeed, Maine's hospitals are excellent. That was the difference between survival or not, the care that he received. I'm glad that he's doing well as his doctor, but he's not so sure. He told me that he's going to have to pay over $200,000 in medical debt. This will obligate him for the rest of his life, he said. The hospital worked out a payment plan with him, but he does not relish the financial cost to his family. Of course, not many others are not as fortunate to fare as well medically. And this is unfortunately especially true for Black, Indigenous, and other people of color, which was a shameful fact of our system before COVID. And of course, COVID has belied a lot more of that. Too many Mainers in Presque Isle and Hodgson and many other rural communities have terribly hard time accessing behavioral health and primary care. This bill is intended to address a big picture paradox. Even though there are good people working hard in all different facets of our healthcare system, and even though we're among the most advanced economies in the world, our way of providing healthcare is, number one, unsustainable, and number two, unsatisfactory in so many ways. My testimony is going to briefly, number one, convey how the status quo is unsatisfactory and unsustainable. Two, the evidence basis for this bill. And three, the mechanics of the bill with some proposed amendments, which have been forwarded through Christian Ritchie. Thank you so much for helping with that earlier this week. If you take nothing else from this hearing, I hope it will be the graphs that I shared with the committee and that are available to the public through the document exchange. Graph number one. This shows how far behind the pack Maine is, along with the rest of the country, compared to what other advanced economies are doing with their healthcare systems. If you're looking at that graph, you can see that this plots life expectancy against the overall health expenditures. In other words, all the other economies, all the other countries are grouped together. They're living 3 to 5 years longer than we are. 3 to 5 years. And they're spending a third to half as much as we are. This graph is really dramatic because the situation is really dire. That is the status quo that this bill attempts to address in part. Now, what is 3 to 5 years of life expectancy? Just to put that into perspective, the entire opioid epidemic, as awful as it is, has diminished life expectancy by a fraction of a year. So 3 to 5 years in the other direction is astronomical. So that's the status quo. And I would venture that it's not sustainable to spend $2,000 to $5,000 more per person in Maine and in this country, in the rest of this country. You'll see on the graph that Maine is actually pretty much middle of the pack in our country, but our entire country is way off the pack in terms of what is possible with the healthcare system. So think of Mike when you think of those 2 to 3 times more expensive healthcare per person. Indeed, there's a lot that has improved in the state and federal levels, but this bill intends to improve things more. And what's the evidence basis? The common thread running through all the systems that are far outperforming us. We wouldn't even qualify to go to the Olympics, much less medal in the Olympics, if that were what was going on. We're not even like in the top couple dozen. So, but the countries that are doing so much better than we are do a lot more for primary care. Graphs 2 to 4 explain this a little bit more, and I hope that you'll look at that because that's very important. These graphs are basically the same graph. Essentially, what they show is that the more a system is oriented towards primary care, the greater percentage of all its healthcare spending that is spent on primary care, the better the outcomes are, and the lower the costs. So those could be outcomes like emergency room visits, unnecessary hospitalizations. The more primary care oriented a system is, the fewer emergency room visits and unnecessary hospitalizations there are. In other words, the better the health is for your constituents and mine. For every 10 additional primary care physicians per 100,000 people, it's associated with a almost 2-month increase in life expectancy. Again, that is a very dramatic increase. I submit that we are self-harming ourselves when we have a system that orients us away from primary care. And I think we can do better in Maine. It would also improve equity, as I mentioned, and the Association of State and Territorial Health Officials has pointed this out. There's broad consensus also that behavioral health or mental health, whether delivered in a primary care practice or in any other setting, hospital, other outpatient setting, et cetera, is crucial. It's reflected in state-level bipartisan proposals, such as in what Massachusetts is working on right now. The opioid crisis, COVID-19, and this legislature's budget deliberations all point out how important behavioral health is and how underfunded it is. So part of our challenge is applying what we know in terms of all this evidence to Maine. Maine has particular circumstances. We are largely rural. We have important safety net hospitals. We have an relatively old population. We don't have many private insurers. We have an oligopoly with only 2 large healthcare systems, 2 large hospital systems. Again, they provide excellent care, but it is a factor. We have the opioid epidemic that is hitting us hard. We are the 43rd nation in GDP. And of course, we're constrained by things like ERISA, laws like ERISA, which I know this committee is very familiar with. So we need to apply the evidence that I've laid out and what those graphs show to our Maine situation. I don't think it's too hard to do. I know that we can find a way forward in Maine. So let's look under the hood. LD 1196, I'm going to briefly summarize it. It would require that the percent of overall healthcare costs spent on primary care and behavioral health incrementally increase for 4 cycles by at least 1 to 2%. So on graphs 2, 3, and 4, we essentially would move to the better end of those graphs, the less expensive end, the better health end of all those graphs. The printed bill envisions a 1-year interval. I have submitted amendments, I respectfully submit amendments to increase that interval to 2 years for technical reasons. We can go into that if there are questions later. So for example, if the primary care behavioral health percent spend, the percent that is devoted to them, were 6% at baseline for a private insurer, in the first cycle, that insurer would need to increase that from 6% to 7% if they're kind of ahead of the pack in terms of their orientation. But if they're below the median for other private insurers, then they would need to increase that by 2% to 8%. 2 years later, the median would be recalculated and the system would, it would iterate. The superintendent of insurance would ensure these goals are met, but only for the plans that that office regulates. In other words, not for the large group rates. I recognize that there's only so much that this committee has oversight over and so much that the state can really affect. This has been done in New England and it worked. It worked in Rhode Island. Rhode Island did this about 10 years ago. So anybody who says this is impossible can look to Rhode Island. Their healthcare costs dropped by 14% in just a handful of years. Another huge compelling thing. They also increased the number of the concentration of primary care physicians and specialists. Interestingly, the system just was working better. Now, Rhode Island implemented some price controls for hospitals. That was an important feature of that system. I would propose, actually in a second amendment that I've shared, that those cost controls be softened, that maybe the duration be extended, a transition period of perhaps 4 years, to allow us as a system to move from fee-for-service towards a more value-based approach. Value-based care is where everything is going. It's where Rhode Island's going. It's where Oregon is going, and all the other and the states that are leading on this, and are basically joining the economies that are leading on this. I won't go into. I'll skip over the section where I talk about the hazards of keeping that fee-for-service, but happy to address that if the committee has questions. The third amendment I would propose is to stagger action on primary care and behavioral health. We simply know more about primary care than we do about behavioral health. Part of this is because of the national studies. Part of this is because in Maine, 2 years ago, Senator Linda Sanborn's primary care transparency bill, which became law, has given this committee, your committee, more information. The Maine Health Data Organization and Maine Quality Forum has submitted a couple of reports to your committee showing that Maine is basically middle of the pack in terms of primary care orientation. In other words, we can do a lot better. Middle of the American pack, which is way off track, as graph 1 showed. So in conclusion, I want you to understand that I know that this seems like it's a big thing. And in a sense it is. It's a nudge in, I think, the right direction. There are known unknowns. We don't know exactly how genomic medicine, for instance, will affect healthcare or healthcare costs. We don't know exactly what other pandemics or what the next chapter of this pandemic is. There are always known unknowns. But if we wait until everything is known, we will wait for eternity before fixing our system. And I'm proposing this as an incremental fix. So let's think about Mike, his $200,000 in medical debt. Let's think about our communities, ask our mayors or our school boards what they would do if they didn't have to spend so much money, or any business owner who provides health insurance for their employees, what they would do if they didn't have to spend so much of their money on healthcare. You could lower taxes, you could fund education. There's so many priorities that run across the political spectrum that would be helped if we can address this problem. I do believe we can get there. I know that there needs to be a bit more conversation. I have found this a bruising experience over the last better part of a year working on this with stakeholders. I understand that there are a lot of details here, but I also know that what I'm proposing here is proven. It's proven in New England. It's proven in another way around the world. The goal isn't simply to pass a bill, it's to achieve good health outcomes and lower costs for our constituents in the entire state of Maine. I would be happy to answer questions, but I'll stop at that point. I thank you so much, Madam Chair, for this hearing, and I really respect the time of the committee members. Thank you.
Thank you, Representative Zager. Representative Morris, go ahead.
Yes, thank you, Madam Chair. And Representative Zager, I can tell from your testimony and the amount of research you've done, you're very passionate and knowledgeable about this. For those of us that, I've done a little bit of looking into the whole value-based thing, but I'm not as well versed on it as you. Can you kind of just expound more on that? Give us more of a background on it and why you think that's so critical.
Thank you so much, Representative Morris. I really appreciate that question. It's a very good one. It's something that I've been working on. I'm not an expert in health systems, and there are people who have PhDs and work on this for 40 years. But I do know how to listen. And I had one conversation with an expert actually who published the Journal of the American Medical Association article, the definitive article on the Rhode Island system. He's a Harvard health policy expert named who said that there's two main problems with keeping a fee-for-service approach, in which case we have this sort of artificial definition of like, here's something intangible. We'll call it a unit of healthcare. It's called the relative value unit, or RVU. We're going to sell that as if it's a commodity, as if it's something that, you know, like a pound of tomatoes. The cost is price times quantity. So if you, in a system, if you cap costs in order to achieve health, you know, keep our healthcare from becoming an ever increasing portion of GDP. If you cap costs, then the quantity has to increase. In other words, all the doctors and nurse practitioners and so forth are going to need to spend less time with all our constituents in order, because the systems will say, oh, we need to, you know, achieve a certain amount of money, and if we can't increase our costs, then you need to do more. You need to spend less time with each patient so you can do more productivity. That's a big hazard. So that's one example of now we can't just do that because it doesn't, you know, we have to account for the quality of care. That is a whole discussion in itself, what quality means. But I'll say that prevention works. Going on a hamster wheel doesn't. I hope that helps.
Thank you, Representative Zager. Are there other questions for Representative Zager? Senator Brenner.
Thank you, Madam Chair, and thank you, Dr. Zager, for joining us this morning. I have a question. I love your charts, by the way. I love data, so they're very helpful. I'm just wondering if you could perhaps speak to what Minnesota is up to and why it's working so well for them to have so few ED visits. Is it? Do you feel like that's related to the spend for primary care?
To be honest, thank you, Senator Brenner. I appreciate your appreciating the data. I don't know as much about Minnesota as I know about Rhode Island and Oregon. There are other folks that actually I for the work session I could could point to, and perhaps we could leverage their expertise. I will say that that in Rhode Island and Oregon, what they did, Oregon especially did an approach of value-based care. I mean, they have their main Medicaid program is one that is oriented toward that more at time zero. So that's one thing. I would have to do some more research to give you a quality answer on Minnesota.
Thank you.
Are there additional questions for Representative Zager? Representative Brooks.
Yeah, I appreciate your solution-based model, and I think the example you gave at the beginning of patient that you called Mike is very telling. How often, as a practicing physician, do you see people that are having very much more advanced disease because they lost access to primary care physicians?
It's hard to know the negative. In other words, we know that there are people who have a heart attack, for instance. I don't know if this person who had the heart attack had it because they didn't have access to primary care, or that person didn't. I know, but we know with these studies, and I tried to summarize it with the graphs that I shared, is that in the aggregate, we are missing the boat. And so access to primary, when the basic question that a lot of people asked over the last 20 years and basically have answered is, what are the features of these systems that seem to be working? The answer has been primary care. Barbara Starfield, actually, her work with Johns Hopkins going back 20 years, actually she was one of the key scholars that kind of pointed this out and clarified it using international data as well as national data and breaking it down by states. And so, like, the same phenomenon is repeated regardless of which scale you're talking about, really adds weight to the finding. And so, so I can't point to Representative Brooks, that your good question. I can't point to which which patient, Mike, maybe he would have had, I don't know actually his lifetime exposure to primary care. I don't know if he's had a lot of primary care. I could look into the chart and find that out. But we do know in the aggregate that primary care is a very, very consistent feature of systems that work, that are doing a lot better than ours, as graph 1 shows.
Are there additional questions for Representative Zager? Representative Connor?
Thank you, Madam Chair, and thank you for being here, Representative Zager. It's nice seeing you in both of our committees. The question I have is, does the bill speak to the quality of care, or is it more of the quantity? Is the bill trying to get a wider breadth of care in the state versus focusing on the quality of that care? Can you just speak to that?
Thank you so much, Representative Connor, and it is great to see you in this committee as well. You've put your finger on I think the piece that I have wrestled with perhaps the most, and it's not something that I, as an individual legislator or physician, could figure out the details of. Exactly how to account for quality is something that is wrestled with. When talking to private insurers, they would like to share the attention to that, because share the risk basically. If you, I guess in the shortest way of saying is that I think that getting stakeholders together during the 4-year interval that I propose in my amendment, that's actually why I created that is to have those stakeholder conversations to figure out, okay, are we going to measure the A1C, measure the A1C? Are we going to measure tobacco cessation efforts? Are we going to, et cetera, et cetera? Certainly opioid, dealing with the opioid. I mean, there's so many things that can be discussed in the discussion of quality. And I think that this bill creates that space for the important conversation that you just asked about. I don't have it packaged up neatly for you because, and frankly, that's a pending an ongoing conversation in other places like Massachusetts, and so essentially, I think that you can look at this bill as creating a space for that, and I would look forward to seeing that conversation occur with the people who are delivering care. I mean, listen during today's testimony. Listen to the people who are closest to the patient. They are important stakeholders. The patients themselves are important stakeholders, right? I mean, we're all patients. The hospitals are important. The non-hospital primary care practices, the specialty practice. I mean, there's a lot of the payers, main care. There's a lot of stakeholders, and I think that conversation needs to be pushed. This legislation, I think, can push that conversation, and I think it's a really important one, Representative Connor.
Thank you. That's all I have, Madam Chair.
Are there additional questions for the sponsor of the bill? All right, seeing that, we thank you for your testimony, for bringing us the bill this morning. So again, I'll announce that for all non-legislative members who are all non-members of the legislature who are going to be testifying, we are going to use a 3-minute clock in order to keep us on time. If there are committee questions, those would be after the 3 minutes and outside of it. So just to clarify that for folks. Also, because we have a lot of folks who haven't joined our public hearings before, I do want to just mention that as we bring you in to testify, it'll feel like you're being kicked out of the Zoom meeting for a moment. We're pulling you through the wormhole of the Zoom universe, and you will reappear shortly on our panels. So just sit tight. Don't worry. Don't take any drastic action with your computer. And then unmute yourself and turn on your camera when you have joined us. We'll start with Patrick Connolly, and then followed by Susanna Daggett and Megan Driscoll. So once Mr. Connolly is with us, we will hear from him, and I'll start the clock. Go ahead, Mr. Connolly.
Good morning. Thank you, Senator Sanborn, members of the committee. My name is Dr. Pat Connolly. I'm a family physician practicing in Portland, Maine. And I'm here in testimony in favor of LD 1196. May also add, I'm the immediate past president of the Maine Academy of Family Practice and a professor of family medicine at Tufts Medical School. For too long, our healthcare industry has been incented to provide more medicine, but what we need is a system that promotes better health. Healthcare systems that invest in a robust primary care workforce have been consistently shown to provide better healthcare outcomes at lower cost. I've been fortunate to be able to work in the same practice at Martins Point in Portland for over 27 years. And I've learned the value that well-supported primary care can provide to my patients. There are 4 components to effective primary care. We call them the 4 C's. You have first contact accessibility, the place to call and be seen when you have a problem. Second is comprehensive care, the ability to provide quality care for the vast spectrum of the usual problems our patients face. Family doctors can manage about 85% of all problems that come through their doors. Third is continuity of care over time. It's much easier to take care of someone if you know their history and that of their family. Fourth is care coordination with other specialists and services. I want to share with you my experience with one of my favorite longtime patients and her family. I've been privileged to care for 4 generations of this family, and I've been able to provide these 4 cardinal components of primary care. Jane, I've changed her name for privacy issues, came from a generation that dressed up to go to the doctor. Though in her 80s and in frail health, she never failed to show up to the office in a fashionable dress and heels with open toes, even though she could barely walk. I always made it a point to compliment her on her pedicure, and she was pleased that I noticed. I managed her diabetes and COPD for over 20 years. When her son came to me with shortness of breath, I diagnosed atrial fibrillation and abnormal heart rhythm and treated it and coordinated care with his cardiologist. Another family member struggled with alcohol, and I treated her repeatedly over the years with medicine to help prevent relapse and convinced her to go to substance counseling. The granddaughter had depression, which I treated and helped her get better. When the granddaughter became pregnant, I provided prenatal care and delivered baby Benjamin. It's been a joy to watch that child grow. But about a year after Ben was born, Jane, now in her late 80s, had a stroke. Sadly, I helped coordinate with the hospice team that provided her end-of-life care. I've been able to provide this care to this family and the rest of my patients with a lot of support from my staff and the investment in primary care management that Martins Point has provided. It's a model that has worked well here, and I'd like to see that expanded to the rest of the state. I doubt that I'll still be practicing when the 5th generation of this family appears. It's imperative that we invest now so that the next generation of primary care providers can thrive. By doing so, we can ensure better health for Jane's family and for all members, Mainers. I urge you to vote yes on 1196.
Thank you, Dr. Conley. Are there questions for Dr. Conley? All right, seeing none, we'll hear from Susanna Daggett, followed by Megan Driscoll and Ed Fallon.
Hi there.
Good morning. Go ahead.
I'm Susanna Daggett. I'm a 4th-year medical student in the Tufts University Main Track program, and I grew up in Yarmouth, went to school in Boston, and returned to Maine to study medicine with the goal of becoming a primary care doctor and practicing in my home state. Thank you to the chairs and committee members for the opportunity to provide testimony in support of LD 1196 today. So one of the reasons why I'm so excited to go into primary care is the capacity to make a real long-lasting difference in a patient's life. And here's one example. So this year I was working with a patient at Togus VA Hospital who was struggling with severe PTSD from a traumatic event during her service. She'd also lost her job at the beginning of the pandemic, and with isolation and some of her trauma resurfacing, she was using alcohol to cope. And when I met her, she was scared and alone and seeking help. And in the primary care and integrated behavioral health model, we were able to get her connected with a counselor who focused on trauma. We monitored her risk of alcohol withdrawal and helped her stop drinking safely, with a nurse on our team who called her weekly to check in and strengthen her motivation to cut back. A social worker in the practice also helped her apply for some unemployment benefits that she didn't know that she was eligible for. And 6 months later, when our paths crossed again, She was sober, she was in a much better place with her mental health, and she was really optimistic about her future. So in treating root causes, primary care has the potential for the biggest impact. I've seen a patient hospitalized twice for a severe foot infection when what they really needed was long-term treatment of their underlying diabetes and safe housing so that their feet could be warm and dry. Primary care is so inventive and persistent and adaptive, and more we're drawing on the expertise of an interdisciplinary team with our behavioral health colleagues, and patients are seeing the benefit. Our payment models just need to catch up. So LD 1196 would help Maine move to a system that emphasizes health and prevention, treatment of the whole person, and will ultimately help patients live their best lives. Thank you for your time.
Thank you, Ms. Daggett. Are there questions? Seeing none, we'll hear from Megan Driscoll, Ed Fallon, followed by Sarah Hemphill. Good morning, Ms. Driscoll. Go ahead. You're on mute. You're on mute. There you go.
Hi there. Thank you for your time. Dr. Zager asked me to join and just give some testimony from the perspective of a primary care provider. Excuse me. I'm a family practice doctor in Gorham, Martins Point Healthcare. I'm also the chair of our Martins Point Resiliency Committee, which is a team focused on provider primary care burnout and resilience. This statement is really regarding primary care in Maine and the role of behavioral health, and certainly in significant support of this legislation. Primary care providers currently are feeling very overwhelmed by the psychiatric needs of their patients. And this is taking up a really large percentage of their patient care time and contributing to provider burnout. Primary care providers are currently managing and treating a significant amount of mental health and substance use issues, and now are almost entirely unable to offload very complex psychiatric and substance use disorder patients to those with the necessary expertise and training. Community resources are extremely limited in terms of behavioral health, leading to difficulty with referrals and very, very long wait times for both counseling and psychiatric diagnostic and medication management. For example, the current wait list for geriatric psychiatric consultation at Maine Med is about 8 months. This lack of psychiatric resources is especially problematic for Maine care patients. The long-term goal for a lot of healthcare organizations is certainly integration of mental health services into primary care, but this is not really imminent. We are in need of both short-term and long-term solutions. This has sort of reached crisis proportions with the COVID-19 pandemic, which has increased the frequency and the severity of mental health problems in the Maine communities, and really has led to a mental health crisis that has become a primary care crisis due to lack of access to appropriate mental health care. So this statement really is in support of the importance of primary care and also behavioral mental health care and improving access for our communities in Maine. Thank you.
Thank you for your testimony today. Are there questions for Dr. Driscoll? All right, seeing none, we'll next hear from Ed Fallon, followed by Sarah Hemphill and David Howes. Good afternoon, good morning. I was doing the opposite yesterday. Good morning, Mr. Fallon, you can go ahead. We can't hear you or see you just yet. If you could start your camera, there you go, and unmute yourself and you can go ahead.
Okay.
There you go.
Okay, good morning.
Good morning.
Senator Sanborn, Representative Tepler, and honorable members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. Thank you for the opportunity to testify today in favor of LD 1196. My name is Ed Fallon, and I am here today as a member of the Maine People's Alliance member lobby. MPA is Maine's largest community action organization with over 32,000 members across the state. Our mission is to create a world where everyone has what they need, contributes what they can, and no one is left behind. MPA supports LD 1196, which would increase the investment made by health plans in both primary care and behavioral health. We all know that our healthcare system is one of the most expensive in the world, and that our health outcomes do not match how much we pay. Other states have begun to shift resources towards primary care as a way to both improve outcomes and lower costs by preventing health issues and better managing chronic disease. This bill is an opportunity for Maine to apply their lessons learned, expand the idea to include behavioral health as well. This is especially important in a state where so many of our residents are older and more likely to have multiple chronic health issues. As a veteran, I am concerned that returning veterans with PTSD or other mental health issues will not find their way to proper treatment and turn to harmful drugs as a way to self-medicate. After serving our country, we should not abandon them to manage their mental health on their own. This bill will increase the resources available for our veterans and all Mainers to get access to the treatment they need and support those with substances and disorders on a path to recovery. Investing in primary care and behavioral health is also a critical step towards addressing the racial disparities in our health outcomes that have been laid bare during the pandemic. Maine at one point had the greatest coronavirus racial disparities in the nation. This is a moral issue as well as a healthcare issue. Research has shown that investing in primary care can address health equity because it invests in the system with the widest reach and greatest continuity. Investing in primary care is also a fiscally and economically pragmatic policy. Upstream healthcare interventions reduce healthcare costs. Rhode Island was the first state to enact safer policy. Between 2008 and 2012, Rhode Island increased primary care spending from 5.7% to 9.1% and has total healthcare expenditures fall 14%.
Mr. Fallon, could you wrap it up for me, please?
Yes, ma'am. LD 1196 will steadily increase resources, and as a result, access to this critical primary care and behavioral health care in Maine that we need. This will help us better prevent and manage our health issues, reduce the racial disparities in our health outcomes, and lower our long-term care costs. Maine People's Alliance supports LD 1196 and the steps it takes towards leaving no one behind. I urge you to vote ought to pass. Thank you for your time.
Thank you, sir. Are there any questions? All right, seeing none, we'll hear from Sarah Hemphill, David Howes, followed by Sean Martin.
Good morning. Thank you, Senator Sanborn. And thank you to the rest of the committee. My name is Sarah Hemphill. I use she, her pronouns. I am also a fourth-year medical student in the Tufts University main track program. I grew up in Falmouth and I just moved back to Portland after spending my third year at Franklin Memorial Hospital in Farmington. Throughout the past year, I saw patients on a daily basis who came to the emergency room or were admitted to the hospital in Farmington with conditions that could have been prevented by better primary and behavioral health care. One particular patient comes to mind who over the course of my 8 months there had 5 hospitalizations for alcohol detoxification, several of which required ICU level care. They were given IV medication until their withdrawal symptoms had subsided and subsequently discharged with no guarantee of outpatient follow-up care. Alcohol use disorder is very difficult to treat, but this cycle of hospitalizations and relapse without addressing the underlying addiction was certainly not the way. This patient needed robust outpatient evidence-based care from substance use counselors and primary care providers, which he did not have access to. This year, I will be applying for residency in family medicine, and I hope to match here in Maine and ultimately practice here in my home state. Specialty choice for medical students is complicated and definitely multifactorial. However, I have heard many classmates express interest in pursuing primary care specialties, but ultimately decide on something else due to extreme debt burden and high levels of stress and burnout in primary care. I am fortunate that the financial barrier has been made lower by a generous Maine Track scholarship and help from my family. But for most, this is not the case. This bill is a much needed step towards reducing preventable hospitalizations, recruiting and retaining a larger primary care workforce, and appropriately compensating the true value of primary and behavioral health care, and I urge you to support it. Thank you for your time.
Thank you, Ms. Hempel. Are there questions? All right, seeing none, thank you for joining us today, and thanks for staying in Maine. Next we'll hear from David House, followed by Sean Martin, Elizabeth Fowley Mock, and Lauren Nadkarni. Christian, do we have Mr. House joining us?
He's on the call and I've added him 3 times now and it's just not coming through.
Okay, let's skip over him and pull in Sean Martin, and then we'll try again. And Christian, you can feel free to try and add him while Mr. Martin is testifying, and we'll just get to him next. All right, Mr. Martin, go ahead.
Well, good morning, Chairwoman Sanborn and members of the committee, and thank you for the opportunity to join you this morning to speak in support of LD 1196 and the need for the state of Maine to increase investment in primary care and behavioral and mental health. My name is Sean Martin. I'm the Executive Vice President and Chief Executive Officer of the American Academy of Family Physicians. You have heard from a few of our practicing members in the state of Maine, and 2 that I was thrilled to hear this morning are on their way to being practicing family physicians in the state of Maine in the very near future. The AAFP 6,000 family physicians and medical students, including over 800 in the state of Maine. We are the largest physician organization in the country solely devoted to primary care. So again, thank you for the opportunity to speak in support of this legislation. I am going to be brief and organize my comments in 3 segments. 2 are reasons building upon Representative Zager's comments about why this is important from a population and healthcare perspective, and then a little bit of the outcomes that you could expect from an increased investment in primary care. As Representative Zager and others have said, we are an aging population that is growing sicker by the day. It is estimated by the year 2060, almost 100 million individuals in the country will be over the age of 65. We know that today, 6 in 10 Americans have 1 chronic condition, 4 in 10 Americans have 2 or more chronic conditions, and 30 million people have 5 or more chronic conditions. Why is this important? Well, we know that we spend about $1 trillion related to the care of chronic conditions in the United States today, and uncontrolled and unchecked chronic conditions often end up in very expensive hospitalization or emergency use care, when primary care would be a lower cost, higher value alternative for those patients that would help keep them healthier and use our resources, financial resources, more efficiently. So as we have seen this explosion in the number of chronic conditions and the aging of our population, including in the state of Maine, we have actually seen a decrease. So between 2002 and 2016, there was actually a 1 percentage point reduction in the overall investment in the country in primary care. And between 2016 and 2019, we saw a 0.5% reduction in the overall investment in primary care in the country. So at a time when primary care could benefit individuals and populations more, we are actually seeing a reduction in our overall investment towards those high value services that are so important to our communities and our fellow Americans. So why does this matter? Healthcare systems that have a higher orientation around primary care have 3 key indicators. They have better health outcomes, they have longer life expectancies, and they reduce cost. But more importantly, patients are more satisfied and your physician workforce will be more satisfied. So again, thank you for the opportunity to join you today, and I will speak in support of this bill one last time. Thank you, Madam Chairwoman.
Thank you. Are there questions? All right, seeing none, I see that Dr. House has joined us, so please go ahead.
Thank you very much. I apologize for the difficulty in connecting. Good morning, Senator Sanborn and members of the Committee on Health and Health Services, Insurance and Financial Services. Thank you for the opportunity to make some comments. I'm Dr. David Howes, primary care physician. I practiced for the first 10 years of my career in the wonderful island of Deer Isle, Maine, in the community of Stonington. I'm now the president and CEO of Martins Point Healthcare in Portland. As you know, we're a not-for-profit health plan and primary care organization that's based in Portland. A little bit about my personal journey. I'm a son of a family physician, and in fact had the enormous pleasure over the years to care for people that my father had cared for, who I came to know dearly. But in the early 2000s, as I was just leading Martins Point for the first time, I began to ask myself if primary care still mattered, as specialty care became the more dominant way of providing care in our system. And I made the journey to visit Dr. Barbara Starfield, who Sam Zager actually mentioned earlier today, a pediatrician and health service researcher who really had cemented the literature around the impact of primary care, both in the United States and around the world. And she basically provided me with the same information that Sam mentioned, that when you add 10 primary care physicians to a large community, you see a reduction in mortality and an improvement in health status, not seen with the addition of specialties. She also made a strong point as a pediatrician that it improved the care of children and it improved the care of pregnant of women. Her reasons for that, she believed that the reasons are that it's continuous care, that it's comprehensive, that it's personal as opposed to being disease focused, that it's accessible, that it increases equity, and that it is offered at the level of the community. She didn't say that hospital and specialty care weren't important, but she felt that it was important that 50% of physicians need to be in the community doing primary care work. At Martins Point, we have really spent a lot of time building a system. And what I can tell you is that cost reduction, that we get the best health, the best satisfaction, and the lowest cost for those people cared for in independent primary care, and want to advocate for that and advocate for the fact that we should support primary care to improve health access and equity. This bill is not a panacea, but it will move us in that direction. Thank you very much.
Thank you, Dr. House. Are there questions for Dr. House? All right, seeing none, we'll next hear from Elizabeth Valley Mock, followed by Lauren Nedcarney and Julie Shermer. Oh, I apologize. Representative Evans, I didn't see your hand go up. I apologize.
That's, thank you, Madam Chair. Just one quick question for Dr. Howell. Thanks for being here. I just wanted to ask, how large is the turnover in family practice that you are seeing today? Are you
Dr.
having that
House,
problem?
Dr. House, you may not have heard the whole question because you went away and came back for us for just a moment. So you're on mute if you want to take yourself off mute. And the question was about the rate of turnover in family practice.
I would tell you that it has taken some, I can only speak from the point of view of Martin's Point. But what I will tell you is that what we are seeing is actually a declining rate of turnover. Once clinicians enter the system and establish a practice, as long as we are able to support them well through their electronic health record, through their supports teams, and with adequate compensation, we find that our turnover in a system with about 100 providers. Does that answer your question, sir?
I think so. Thank you very much.
Are there additional questions for Dr. House? All right, thank you. And so
Thank you.
Thank you. So next we'll hear from Elizabeth Valley Mock.
Hi, I'm Elizabeth Mock. I'm from Bangor. I am parked, speaking in favor of this bill. Thank you, Madam Chairperson and the members of the committee. I'm speaking on my own behalf as an individual. I'm a physician board certified in both family medicine and addiction medicine, and have spent much of my career focusing on inpatient hospital care. For the past 12 years, I've worked the evening shift at one of the state's larger hospitals. I've also worked at 3 different critical access hospitals in Maine's rural areas. When the people of Maine have not had the benefits of comprehensive continuous primary care, it becomes painfully obvious in times of crisis. One of my mottos is, every sick patient in the hospital needs a good family doctor. Whether I'm assisting in delivering a baby in the emergency department, performing a gynecological exam on a critically ill patient in the ICU, or having a difficult end-of-life conversation with family members, always at 3 a.m., I have the skills to address in times of crisis that frequently should have been addressed as an outpatient. You've heard about investing in primary care, that it will result in fewer emergency department visits and total number of hospitalizations. And in fact, hospital care accounts for 38% of total healthcare spending. When I am working in the hospital, I see that small percentage of patients with chronic disease who get admitted repeatedly, like the elderly woman with heart failure who stops taking her medicines intentionally when she starts feeling lonely and anxious, like the patient who had a heart attack and he's so worried that he might die every time he has a twinge of chest pain, he comes to the hospital 10 times in 6 months and gets admitted every time with no primary care follow-up in between. And like the person who hasn't seen a doctor at all in 10 years, comes in with a stroke and becomes debilitated, and then he's surprised to hear that he actually has high blood pressure, diabetes, and high cholesterol. Requiring a larger portion of healthcare dollars in Maine be spent to deliver primary care will move us closer to the Institute of Healthcare's quadruple aim. It provides better patient care at lower costs, with increased satisfaction for patients and families, and a happier, more stable workforce. I look forward to the day when our hospital census does not increase year upon year, because every patient in Maine has a primary care medical home that is equipped to treat the body and mind, address chronic disease and addiction, and support patients' capacity for self-management toward healthy lifestyles. Thank you for considering a vote ought to pass for this bill.
Thank you very much, Dr. Mock. Are there questions for Dr. Mock? All right, seeing none, thanks for joining us from the parking lot today. Next, we'll hear from Lauren Nedkarni, followed by Julie Shermer, followed by Silvana Sidorskas. Good morning. Go ahead.
Good morning. Thank you to the chairs and committee members for having me today. My name is Lauren Ned-Carney. I'm a family medicine physician and sports medicine physician at Central Maine Medical Center in Lewiston, Maine. I serve as a family medicine faculty member within our family medicine residency, as well as a teacher at the University of New England College of Medicine. And I'm here to support Bill LD 1196. We know that investing in primary care and behavioral health improves health, lowers healthcare costs, and helps Mainers lead productive lives. This is really a win-win bill here. There are a few examples which illustrate how essential access to and appropriate funding for primary and behavioral health care is for our community. One is that access to a primary care physician reduces emergency room visits. I have several patients, too many to name here today, but you've heard a few through the prior testimonies, who would frequently use the emergency room as they had nowhere else to go. Once they had obtained insurance and or established care with a primary care provider, their healthcare needs and expenditures decreased, and it seems that their health tends to improve after the fact. In a resource-limited setting, such as in many areas in Maine, access to specialists is nearly impossible, and therefore the burden of caring for complex and chronic diseases falls to the primary care providers, who also care for a significant burden of mental health disorders. This is certainly true in my own clinic. During the COVID pandemic, primary care offices have been essential in managing complex and chronic diseases in efforts to reduce the burden on inpatient medical services, which have been exhausted due to COVID-related conditions. As was mentioned previously, this includes a significantly increased burden of depression, anxiety, substance use, and other mental health disorders in the setting of the COVID pandemic and its after effects. Another example is that increasing investment in primary care and behavioral health care may allow further implementation of technological services, such as telehealth visits, to reach a larger population of Mainers who would otherwise not have access to this care. This has very recently and distinctly impacted our rural communities of late, especially in the time of COVID. And we've seen great benefit in being able to care for patients virtually whom we may not have otherwise been able to care for. This includes patients who live in rural areas and people who cannot take time off from work, who lack transportation, or who reside in a group living environment, such as a nursing home. There are several economic models which show that increasing primary care expenditures actually decreases overall health costs. And you've also heard a lot about how increased investment in primary care will help to reduce the physician shortage in this field of medicine. Thank you for your time. This bill is a great step toward improving both the quantity and quality of the health of our shared communities, and I hope you'll vote yes on Bill LD 1196.
Thank you for being with us this morning. Are there questions? All right, seeing none, thanks for joining us. Next, we'll hear from Julie Shermer. Good morning. Go ahead.
Good morning. Good morning, Representative or Senator Sanborn and honorable committee members. My name is Julie Shermer. I'm a Falmouth resident and current co-chair and vice president of, or co-chair of the policy committee and vice chair of the board of directors of NASW Maine, which represents the 5,000 or more licensed clinical social workers in the state of Maine. So I am not going to, I would refer you to my written testimony that talks about the evidence and the reasons why we are in support of this important bill. And I'm going to really focus on the behavioral health piece. As in my position over the past 35 years, I have been an integrated behavioral health provider, a medical educator of many, if not most, of the medical physicians who have shown up today to testify. I've been a healthcare planner in Fairfax County outside of DC. So the reason why you want to support the behavioral health component of it is that depression and untreated depression is one of the top 3 illnesses that negatively impact quality of life, functioning, morbidity, and mortality figures. And data shows that integrating behavioral health providers into primary care provides care when patients need it at the point of care, when it's assessed early on, it decreases overall costs, specifically related to decreased ED visits and length of stay for hospitalizations. So if I could, I'm going to tell you about two patients. And I'm going to start with, say, Tina. Tina was a 45-year-old mother who I worked with. She worked at Walmart in the meat department. She had a history of diabetes, PTSD, and recurrent depression. When I saw her 2 days after her recurrent depression arose again, related to work-related stress. We were able to intervene early on. She really needed to take some time off, went on short-term disability for about 6 months. We did one-to-one treatment for 6 visits, and then I got her into a preventive and wellness group medical visit that we've been doing at our site. So she made it. Tina was not so lucky. Tina had similar illnesses, but she had minimal health insurance, and her depression really affected her ability to care for herself. She scared the life out of me one time when she passed out in my counseling office due to low blood pressure or blood sugars. Anyway, I urge you to support this. I urge you to support upstream medicine and for the lives and health of our community members and our economy. So thank you.
Thank you very much. Are there any questions? Excuse me. All right, seeing none, we'll next hear from Silvana Sidorchuk, and I appreciate all of those who have texted me telling me how to pronounce this person's name. Good afternoon, go ahead.
Yes, good morning, Senator Sanborn, Representative Tepler, and members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Silvana Sidorchuk, and I'm a family physician practicing in Madawaska. I'm the president of the Maine Academy of Family Physicians. I'm actively involved in the legislative issues and collaborate with my colleagues on issues pertaining to practice of family medicine in Maine. I'm not different from any other family doctors that practices in rural Maine. My community is isolated and challenged with a lack of resources and providers. My days are filled with soul searching and meaningful interactions. It's hard to predict work hours, so it's a time sacrifice that I have decided to make at the expense of my family life. My practice brings a variety of patients, but mostly Medicare and Medicare patients. I see patients of all ages, ranging from newborn to geriatrics. My schedule is usually seeing about 20 to 25 patients a day, with follow-ups, physicals, acute visits. Approximately once a week, I do see patients at the nursing home, assisted living facilities, and I also do home visits for the patients that are homebound. About a week ago, I saw a patient in my office. He came for an acute visit. My medical assistant informed me that he only wanted to see me and no other provider. It's a 60-year-old male, and he wanted to discuss personal issues. As I entered the room, he was quiet and withdrawn. He reported that he wanted to kill himself and that life has no purpose for him. There was a big silence, and he started crying. In this moment, I knew that he came to get help. If I would not have been available, I do not even want to think what could have happened. We talk. He agreed to get help and go to the hospital. I sigh with relief. I think I just saved his life this time. I do all the direct patient care while I check my never-ending messages and answer a million questions from my staff. Multitasking is essential. In between, I discuss cases with my nurse practitioners. It is the comprehensiveness of medical care and complexity of medical issues that makes this field at the same time rewarding and challenging. To me, it's all about forming bonds, relationships, more than just pure science. It's the human touch. As a family physician, I see how better access to both primary care and behavioral health affects our patients and leads to better outcomes. Many patients seen in the primary care setting suffer from underlying psychiatric disorders, and access to mental health providers is extremely limited, especially in the rural place where I practice. This bill is a composite of primary care and behavioral health, and is an innovation from the pioneering work in Rhode Island and Oregon. Maine would be the first. Health systems with stronger primary care and behavioral health investment operate in a more cost-effective and efficient manner. Greater investment in primary care is associated with lower cost, higher patient satisfaction, fewer hospitalizations, fewer ER visits, and lower mortality. The proportion spent on primary care is insufficient. A shift in resources to support greater access to this comprehensive, coordinated primary care and behavioral health model is needed. Currently, Maine has an average of about 5
Can you
to
wrap
9.
up for us, Dr. Sidorchuk? Could you wrap
Okay.
up for us?
Sure. We need to spark interest by medical students to choose family medicine. As statistics show decline, burnout remains high. In conclusion, I would like to say that in order to keep our communities healthy, let's invest in primary care and behavioral health. I would also like to acknowledge the hard work, dedication, and diligence of our legislators. And thank you so much for letting me speak today.
Thank you so much for being with us. Are there questions for Dr. Sidorchuk? I'm just going to say her name over and over now that I've learned how to pronounce it.
It's perfect. Thank you.
You're welcome. All right, seeing none, we'll next call on Isabella Taylor.
Thank you, everyone, Chairwoman Sanborn and the esteemed committee members for hearing my testimony today in favor of this bill. I am Dr. Isabella Taylor. I am a family medicine resident at Central Maine Medical Center, both in Lewiston and in Rumford, sitting in my clinic now. And again, the stories are what really get to me. And the investment of this bill that it wants is an investment in the doctors, the patients, but also I wanted to touch on all the support staff behind the scenes that this bill sees. When we talk about increasing investment in primary care and behavioral health, it's not just in the psychiatrists, the counselors, and the physicians. It's in everyone that makes this team approach for our patients the most important. My patient that I've been working with since I got up here in Rumford, let's call him John. He hadn't been to a doctor in decades. He's 60 years old now, finally decides to come. He has diabetes, newly diagnosed, to the point where I would start insulin right away. But John is smart. He knows that lifestyle is the best long-term care medicine for his health. Luckily, at the time, we had a diabetic nutrition counselor who was able to spend the hour time with him to kind of go over everything. And he worked so hard. In 1 month, he had brought his A1C, one of our metrics to measure diabetes, down a whole point. It was amazing. And he was making strides. I didn't want to start him on medication yet. John also had severe mental health, PTSD, and as we know, COVID did not make it any better. And unfortunately, with his insurance, he wasn't able to find counseling because of costs. My Rumford Center right now, we don't have case management, we don't have social work because we don't have the resources to invest in those, and we really, quite frankly, need to pay them better because they are so important. John can't take care of his diabetes if he's super stressed out. In addition to that, John also and I also rely on the medical assistants who help room him, who, as many of you know, in the healthcare field or friends or family, they are so overworked and so undervalued, and we need to invest in them, not only for the patients, but for retainment and to show them that we value their care, that they are so important to patients. I really want John to keep working on his lifestyle. And he was making great strides with our diabetic nutrition counselor. And because of funding, the way we prioritize healthcare and spending, she was let go. I wish that I had an hour every couple weeks to spend with John and the many patients like him. I wish that I had an hour to spend looking on the internet to shop around for a counselor, but I don't. And so this bill is helping invest in the whole team-based approach for everyone that needs to help John and our other patients work towards their better lifestyle to be the best they can be for all of our communities. Thank you so much for your time.
Thank you, Dr. Taylor. Are there questions for Dr. Taylor? All right, seeing none, thanks for joining us today. And next we'll hear from Betsy Sweet. Good morning, go ahead.
Good Good morning, Senator Sanborn and members of the committee. My name is Betsy Sweet, and I'm offering testimony in support of LD 1196 on behalf of the Behavioral Health Community Collaborative. The Collaborative is a coalition of 8 nonprofit community behavioral health organizations committed to providing compassionate care across Maine. Each year we serve 80,000 people and employ more than 3,000 behavioral health professionals. I am sure you've heard it said that we in this country do not have a healthcare system, we have a sick care system. That is, our system is designed to take care of people only after they become sick, often so severely sick that their treatments are expensive and often they have waited too long for them to be effective. Thus, the vast majority of our healthcare dollars are spent at the most expensive and most ineffective time. Most people don't seek primary care treatment because they do not have insurance or are so underinsured that they cannot pay out-of-pocket deductibles for anything but the most dire care. It is also really hard to find a primary care physician. It just took me 9 weeks of almost constant looking to find someone. Our system has become skewed toward emergency rooms, urgent care, and the most expensive care. We must turn this proverbial ship around and begin to invest in a healthcare system that focuses on health and prevention. This is true for both physical and mental health. We need a seamless system of care. There are no less than 27 bills before the Health and Human Services Committee to try and increase and correct and to improve our mental health system. I think 1196 is an incredibly smart and reasonable way to require insurers to begin to shift their healthcare spending from the back end to the front end. It provides both carrots and sticks, because while every single study and all the graphs you have that show the efficacy of providing help early on for prevention and primary care in both physical and mental health, it has not happened. That's why we need this bill. Behavioral health treatment faces the same issues of primary care, but with the addition that there is a consumer patient stigma for many in seeking behavioral health care. The societal barriers are huge to keep many people away until there is a crisis. But the poor coverage for mental health services by most insurers erect that barrier even further. This is at a time when we see untreated mental health issues playing out incredibly in our schools, our workplaces, our emergency rooms, and our doctor's offices, even our correction system. Imagine if we incentivized early intervention and support, how many of those expenses and the unnecessary human suffering we could avoid. It's this kind of innovative solution that can move us forward in what seems like a perpetually stuck and broken system. It is not the total solution, but boy, it moves us forward. It is beyond time for Maine to prioritize primary care and behavioral health care, and the Behavioral Health Communities Collaborative asks that you support this bill. Thank you, and I'm happy to answer any questions.
Thank you, Ms. Sweet. Are there any questions? All right, seeing none, I will do a last call for those who wish to speak in favor of the bill who are in our Zoom meeting today. And Mr. Moran has raised his hand. Mr. Moran, go ahead.
Good morning, Senator Sanborn, Representative Tepler, and members of the committee. I'm pretty sure I uploaded my testimony, but as you're all well familiar, it comes in at about 9:59 on 10 o'clock hearing, so I apologize for that. The Maine Medical Association is here to support 1196. We're the state's largest professional physician organization across all clinical specialties, organizations, and practice settings. This is one of the bills that was chosen, or one of the issues that was chosen as MMA's, one of MMA's core biennial state legislative platform priorities by our legislative committee and our board of directors. Want to make it clear, our membership includes a wide breadth of physician specialists, including primary care, as you heard me say previously. There's a robust discussion continuing about this bill, and we certainly understand the balloon effect that some opponents or neither for nor against parties might express later in the hearing. We appreciate the feedback from hospitals and hospital health system administrative leaders on efforts to potentially improve the bill, along with the bill sponsor and affected stakeholders. So you've heard the growing body of evidence about overall spending on primary care in the United States. The MHDO, Maine Quality Forum, annual report on primary care spending, resulting from a previous law passed by the legislature, shows Maine with an absolutely similar percentage of spending on primary care to the country as a whole, and you've heard that is low, according to experts. According to a 2019 study, and this is all my testimony from the Robert Graham Center, the spread of public and private payer spend is between 5.6 to 10.2 using narrow and broad definitions. And I would add that this bill that Representative Zager proposed includes a more broad definition of providers as opposed to Rhode Island. This is more similar to Oregon, but the Rhode Island numbers show that this is the way to go. My testimony will show that legislation in Rhode Island and regulatory directives asking carriers to raise their primary care spending similar to this bill showed that primary care spending in Rhode Island grew from 47 million to 74 million between 2010 and 2017. And during 5 years that were looked at from the legislation, total medical expenditures declined by 115 million between 2008 and 2014. So increased primary care, decline in overall spending. Also, there's workforce issues that we're all hearing about. Rhode Island is the only state in New England to see an increased supply of primary care providers per capita, and they also experience an increase in subspecialists. People have already said increased primary care spends result in fewer emergency department visits, hospitalizations for ambulatory sensitive conditions. The report shows that I've highlighted, the report that I've linked to highlights the same thing. And finally, I'll say the Commonwealth Fund's scorecard on state health system performance in 2019 actually shows that Rhode Island improved on the most health system performance indicators, including overall coverage and behavioral health, along with a drop in the uninsured rate. I also have a link to a Blue Cross Blue Shield of Rhode Island brochure that talks about their primary care medical homes, showing that they're 5% less costly.
Thank you, Mr. Morin. Can you wrap up for me?
Yep, sure. And 30 million in savings. So thanks for the opportunity to comment. Sorry, I ran a little bit over. I'd be happy to take any questions and provide more information before the work session. Thank you.
Thank you,
you
Mr.
and Dr.
Morin.
Zager.
Thank you, Mr. Morin. I did want to bring to your attention that you may want to re-upload your written testimony, as the testimony that you submitted was a copy of the bill.
Operator error. Sorry.
Yep.
Thank you.
No worries. Representative Arford, go ahead.
Yeah, thank you, Madam Chair, and thank you, Mr. Morin, for being. Quick question is, again, I had noticed that your testimony was not present. Would you be willing to provide us with the source for the comments you've made on the Rhode Island program and the statistics? I think the statistics that you mentioned were quite dated. I would love to see anything past 2019, 2018 data on what is currently happening in Rhode Island.
Yeah, a lot of times these studies have to go back a few years. And in my testimony, I put links that you can click on, hyperlinks that you can click on that'll take you right to those sources. But I agree with that. But I do have the most latest data from 2020 that'll show charts associated with their continued increase in primary care spending, along with their stability in overall medical expenditures. So thank you, Representative Arford. I'm going to re-upload that right away, and all the sources you're asking for are in the links.
Thank you so much.
Thank you.
All right. Are there additional questions for Mr. Morin? All right. And I see that Catherine Potter has raised her hand. I will just let folks know that I'm working off of an electronic list that I usually load about a half an hour before the hearing. And so that's why I missed a couple of folks today. And that's why I always do a last call before we switch to the next section of the hearing. So here we are, Catherine Potter, excuse me, has joined us, and you can go ahead.
Okay, wonderful. So thank you guys so much, Senator Sanborn, Representative Templer, members of the committee. I'm Katie Swan Potter. I'm a nurse practitioner in pediatrics in Brunswick, and I'm speaking on behalf of our pediatric primary care team at Martins Point Health in Brunswick. So I'm actually taking a specific stance from a pediatric standpoint. I'm speaking today in support of LD 1196, in support of Mainers at a fundamental level from pediatric primary care. As pediatric primary care pediatricians, we help children to create the foundation for a lifetime of healthy habits. In the past year, our role in the healthcare system has never been made more clear. The COVID pandemic has exposed the frailty of our primary care system, and it's exposed its limitations. As the pandemic evolves, our patients are struggling to keep stable the healthy foundations we have helped them to build. Physically, our pediatric patients are beginning to show adverse side effects as a result of poor nutrition, substantial increases in screen exposure, and the loss of organized and informal physical exercise. All are habits that we bolster with our routine checkups. Excuse me. More alarmingly, though, we are seeing a huge increase in the demand of mental health services. I know you've had many people already speak on that. Just at this past week, our team was notified that the only established psychiatric resource we have left in our community is now taking no new referrals. So we are quite literally without any psychiatric care for our patients, for a population in which 1 in 5 struggle with some form of mental illness. This puts the onus on us as primary care pediatricians to both diagnose these, these psychiatric conditions and manage the complexities of mental health polypharmacy and care. The unacceptable alternative is to allow these patients to deteriorate, possibly to the point of acute suicidality, and require inpatient psychiatric care. This further burdens the healthcare system and fails our children and their families. I do have some data in my actual testimony that I sent along, but most alarmingly is at a national level, this level of mental health for children specifically is $247 billion. And that's from the Center of Mental Health Services. So I'm hopeful that this bill under LD 1196 will potentially support these mental health efforts as a preventative level and keep our children alive. So that's really all I have, something simple. And if you have questions, I'm happy to answer those.
Thank you very much for joining us. Are there questions? All right, seeing none, thanks for being with us today. And with that, we will turn to those who are testifying in opposition to the bill. Pardon me, and I will start with Jeff Austin.
Can you see me?
We can, go ahead.
Hi, good morning, Senator Sanborn, members of the committee. My name is Jeff Austin. I'm here on behalf of the Maine Hospital Association in strong opposition to this bill. We've submitted 3 pages of testimony. I'd really like to be able to get through it. You've had an hour and a half testimony about why primary care is good. You haven't had anybody tell you why the bill is good. And I think there's a reason. The bill is fundamentally flawed. It's a math formula. There doesn't have to be a single increase in primary care visits, screenings, or services, and the insurance companies can comply with this law. When they can comply with the law without getting any increase in primary care utilization, you have a flawed bill. This is about rates. The bill says increase primary care spending and cut everything else. How is a carrier going to do that? Through utilization management of hundreds of thousands of patients and literally millions of encounters? No. The only way they'll be able to satisfy this law is by raising rates for primary care and cutting them for everybody else. That's all this bill does. That means no extra primary care has to be provided. This is TABOR. This is an artificial formula. And just like the voters twice rejected TABOR for government, it should be rejected for healthcare. No growth. Even TABOR allowed some growth in government spending. This is 0% total growth for 4 years. That's radical. That's reckless. And worse than that, it's mandatory increases for some providers and therefore mandatory cuts for others. Is this even really an issue in Maine? The leading publication that's out there, that's on page 2 of my testimony, that's not my chart, says Maine is a top tier performer. Everybody keeps saying we're average. Maybe we are. When I look at the leading publication on this, we're a top tier performer. Rhode Island, that's had some version of this law, I've not read the Rhode Island law, and had it for 10 years, they're not a top tier performer. Why are we following their lead? And the sad thing is, we agree with much of the testimony, which was not about the bill. It was about the benefits of primary care. Let's look at that. How do we drive utilization? Is it on our end? Is it providers? Is it Same-day scheduling, weekend hours, weeknight hours? Is it the carriers and lowering copay and deductibles for wellness, for other than wellness visits? Maybe we should look at telehealth. Let's look at utilization. Let's not do an artificial cap. Maine did this in the Medicaid program. You increased rates for some primary care doctors. Did it work to achieve any of these outcomes? Take a look. My final point, I hope you give me my final point, I promise you, Senator Sanborn, belt and suspenders. If they're grabbing their suspenders of primary care spending and saying it's going to work, if you invest in primary care, it'll keep your pants up. Trust us, it works. It will save money elsewhere. Then why are they putting on a belt of artificial cost control? You shouldn't need both. If you believe them, and we actually do, buy the suspenders. Why are you buying the belt? I understand the amendment delays it for 4 years. Why isn't it taken out completely? Either you believe them or you don't. We happen to scrap the belt. That's my testimony. I appreciate the extra 30 seconds, Senator, and I'd be happy to take any questions.
Thank you, Mr. Austin. Are there questions for Mr. Austin? All right, seeing none, thanks for joining us today.
Thank you.
And next we'll hear from Katie Harris from Maine Health. Good morning, Ms. Harris, go ahead.
Good morning, Senator Sanborn and distinguished members of the committee. I am Katie Fulham Harris of Maine Health, and I'd like to start by thanking Representative Zager. I think we share the same goals, and I appreciate he has involved us in constructive dialogue over the last few weeks, and I really do appreciate that. However, as a nonprofit system that focuses on improving the health of our communities, Maine Health sees access to primary care and behavioral health services as the foundation for keeping our patients healthy and our communities strong. But the current payment rates for these services are insufficient to support the level of access that we need to maintain and improve the health of our communities. So we actually agree that increased investments are needed. Unfortunately, as Mr. Austin noted, the artificial cap on total health care expenditures in this bill would force primary care and behavioral health investments at the expense of other critical needs. Some examples of things that could be jeopardized are quality. Someone mentioned that earlier. Maine ranks consistently extremely high in quality, and quality and patient safety require investments in staffing and infrastructure that shouldn't be imperiled by an artificial expenditure cap. Value-based payment structure. We actually now have 40,000 Maine Care enrollees as part of our Accountable Communities program. That takes a lot of cost and effort around things like care management. That doesn't come without cost. Rural access. Maine Health joins other healthcare systems in the state by supporting our rural hospitals that are losing money year after year. Acute care needs. Maine Health's tertiary care hospital, Maine Medical Center, has cared for nearly half of the patients who have been hospitalized with COVID, and we've done so through the flexible use of our new rooms. They have been absolutely instrumental. They were very expensive to build, and yet they have been a key mechanism that we've been able to use to manage our COVID pandemic. And finally, workforce. And you heard reference to the Robert Graham Center earlier today. 60 to 70% of our costs our healthcare costs are labor. And we are facing major labor shortages, particularly in the nursing area. We currently have 457 vacant nursing positions at Maine Health. That proposition costs resources. So I think you'll agree that these are critically important areas and that we don't want to jeopardize by imposing an artificial cap. We do agree that additional investments in healthcare are important, and particularly in primary care and behavioral health, and they should come with accountability. We should track outcomes, and value-based contracts that Representative Zager mentioned are absolutely key. I referenced them earlier. So if the legislature would like to pursue and they agree that these types of investments are important, we would really welcome the opportunity to work together with other stakeholders to define and construct a model of primary care and behavioral health investment that supports the tenets that I think we all agree are important for Maine, which are access, quality, and affordability. So thank you, and I would be happy to answer any questions.
Thank you, Ms. Harris. Are there questions for Ms. Harris? All right, seeing none, thanks for being with us. Next, we'll hear from Lisa Harvey McPherson. Good morning. Go ahead.
Good morning, Senator Sanborn, committee members. I'm Lisa Harvey McPherson, and I'm here to speak in opposition to this bill on behalf of Northern Light. First and foremost, we are in absolute and full support of primary care, and I agree with all the primary care testimony that you heard this morning. I want to remind the committee that you received a report from the Maine Health Data Organization on primary care in January, and Maine actually compared pretty well. In February of 2020, Health Affairs published an analysis of the Rhode Island 2010 affordability standards. And I have detail in my testimony where you can find that article. But what they found was the decline in spending was driven by the lower pricing policies. It was not reduced utilization, as some would tend to believe from primary care providers. Jeff did a good job describing the spending caps in this bill. So I want to think about why those spending caps are flawed when compared to the payers that are targeted in this bill. In Maine Care, we have a number of programs that have targeted growth. They are rebased intentionally to provide cost of living adjustments. Those programs grow on a regular basis. Nursing homes are a good example. Investments in primary care are important. They don't drive nursing home utilization. Aligning investments in primary care and behavioral health to the detriment of other programs that are important to the Maine Care beneficiaries isn't good policy. In terms of mental health, our mental health system is in crisis. Solving the mental health challenge is largely driven by state policy, Maine Care, and federal block grants. If we were to do what we need to do in mental health within this payment methodology, we would overwhelm a system that has spending caps. It's fundamentally flawed. If we think about commercial carriers, I want to think about what much of Maine looks like. A rural community where the largest volume of healthcare is actually primary care, with a rural hospital with high fixed costs because you're caring for a population that is dwindling, is older, is dependent on governmental payers, and you have relatively low volumes in your facility. We know from our accountable care, it is extremely difficult to have rural providers assume financial risk. And that's what this bill does. There's no risk to the carrier. The risk is to the provider. In our rural communities, that's why critical access hospitals are paid at 8% of cost, because of the inherent economic drivers that increase the cost of care in rural communities, even when the largest volume of care is primary care. So we recommend a strategy, and you had a little bit of discussion about value-based purchasing. Let's go down that pathway and really have some strong carrots and sticks around value-based purchasing in primary care that we would all engage in terms of moving that ball forward. And I suspect I'm bumping up against 3 minutes, so I welcome any questions that you have.
Thank you, Ms. Harvey McPherson. Are there questions for Ms. Harvey McPherson? All right, seeing none, thank you for being here today. Next, we'll hear from Michelle Probert. Good morning, Ms. Probert, go ahead.
Good morning, thank you. Senator Sanborn, I'm not sure if Representative Tepler is here or not, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Michelle Probert, and I'm the Director of the Office of Maine Care Services, which is Maine's Medicaid program. I'm here today to speak to some of the department's concerns about LDL 1196 and this bill's application in the main care program. First, I want to share that in principle, we share the goal of increasing relative spending on primary care and behavioral health services across payers. We agree that there are downstream benefits to investing in primary care and behavioral health services that help prevent and/or manage chronic conditions and improve quality of life for patients. I'm going to skip the description of what the bill does because I think that we all get that for right now. But I do want to note that our understanding of this bill is that it does hold the department and the main care program accountable to benchmarks that are based on commercial health plan data. While many have concluded that growth caps and increased primary care and behavioral health spending are appropriate goals for commercial health insurance plans, which have historically paid specialty providers relatively more than primary care, the Medicaid program differs from commercial health insurance in a number of key ways that make the goals of this bill potentially inappropriate for main care. This bill focuses on relative amounts of spending for plans and proposes to measure main care spending against a benchmark set from commercial plans. The main care program provides a different, vastly broader service array than commercial plans. For example, main care provides critical home and community-based long-term services and supports to older adults and individuals with disabilities, broader behavioral health coverage, and case management for various populations. Spending on home and community-based long-term services and supports alone, services that are rarely, if ever, covered by commercial plans, comprises almost 45% of main care's annual spending. Main Care recently conducted an analysis as part of its comprehensive rate system evaluation, comparing reimbursement rates for main care services to those for the same services by other payers. This analysis demonstrated interesting findings in terms of scope of coverage as well as relative reimbursement. For behavioral health, Maine's commercial payers covered only 52% of the service codes Main Care covers for outpatient services, 30% of the codes for adult community-based services, 23% of the codes for substance use disorder services, and none of the codes for children's behavioral health services. Main Care rates for non-tobacco cessation-related substance use disorder services ranged from 143% to 210% of Maine commercial rates. In short, comparing Main Care's relative primary care and behavioral health spending to that for commercial insurers is not an equitable comparison. It is not apples and apples. I will try to summarize the rest of this letter. I will just state that Main Care is not often in charge of its own reimbursement decisions. That often lays in considerable part with the legislature, as well as, to an earlier point, regularly mandated increases. We share the goals of this bill to ensure reimbursement levels are appropriate and to increase value-based care. I do want to share that the department has a goal to tie 40% of Main Care spending to value-based reimbursement by the end of calendar year 2022. We also have an initiative that we hope to roll out this fall to participate in Primary Care First, which is a national multi-payer initiative from the Center for Medicare and Medicaid Innovation, and which helps ensure that our primary care providers receive flexible population-based payment to support increased access to patient-centered care. This bill would come with a lot of implications for Main Care that could disrupt our array of service offerings, also requiring a lot of rulemaking, et cetera. And if this LD should move forward, we do have additional methodological questions and concerns, which we would like to discuss at another time. Thank you for the opportunity to provide this input and make you aware of our concerns. I'm happy to address any questions you may have now or at the work session.
Thank you, Ms. Probert. Representative Evans, go ahead.
Thank you, Madam Chair. Thank you, Ms. Provost, for being here. One question, what is the current overall value-based spending in Main Care?
I can give you that in percentage terms. I don't have the dollar amount, but we we're crunching the numbers right now for the most recent year, but from the previous year, we were at just under 20%.
Thank you.
Are there additional questions for Ms. Probert? All right, seeing none, thank you for being with us today. Next, I will ask if there's anyone else in our Zoom meeting who wishes to testify in opposition to the bill. Please raise your hand at this time. Seeing none, I will turn to those who are speaking neither for nor against and call on Mallory Shaughnessy first. Good morning.
Hi. Am I coming through?
You are. Go ahead.
Great. Good morning. I think we are still at morning. Yep. Senator Sanborn and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Mallory Shaughnessy. I'm a resident of Westbrook and a constituent of Senator Sanborn's. And the Executive Director of the Alliance for Addiction and Mental Health Services. And this testimony is neither for nor against LD 1196, but informational. As is evidenced by the many times we have been before this and other committees, we wholeheartedly share the goal. Sorry, I have a dog in the background. We wholeheartedly share the goal of increasing spending on basic and preventive behavioral health services. Research shows that there are tremendous benefits to investing in the behavioral health services that help to prevent and or manage recovery with mental illness, both in human and monetary terms. We know that mental health is a huge issue in Maine, and 1 out of 4 Mainers affected by mental illness before we even encountered the pandemic. And he agrees with me. We also know that the Maine Shared Community Health Needs Assessment in 2019 found in all 16 counties of Maine, they ranked mental health and substance use as top contenders for health priorities. Sadly, more money is spent per person for behavioral health in Maine in the deep end of the pool when someone has ended up in our emergency rooms, in jails, where problems have escalated to impact every aspect of the person's life, disrupting their family, friends, and the community. Our understanding, though, of this legislation is that its intent is to seek to front load funding in behavioral health, which we agree with, to put more resources into the basics of assessment and early treatment in a preventive way. But it just speaks to behavioral health care in a way that doesn't seem to mandate and target those expenditures toward that front end services rather than the hospital stays or the more intensive services. And we feel it kind of misses the mark by not targeting that better. We also have concerns, as I think others have mentioned, around the phrase that says health plans shall meet the targets, yep, thank you, without increasing spending on total health expenditures. We believe increased expenditures on behavioral health are warranted and needed. So we do like the amendment, though, that talks about doing the Maine quality form measurements for behavioral health as they have been doing for primary care, because we think that that would yield much needed information for future planning. And with that, I thank you very much. And I will end and answer any questions if you have them.
Thank you, Ms. Shaughnessy. Are there any questions for Ms. Shaughnessy? All right, seeing none, thanks for joining us. Next, we'll hear from Catherine Pelletreau. Good morning, go ahead.
Good morning, Senator Sanborn, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans. I'm here to speak neither for nor against LD 1196. I will say at the outset that I appreciated Representative Zager's efforts to communicate about this bill. In advance of this public hearing, we had some really very good discussion. And as I expressed to him, I'll also express to you that this primary and behavioral care spending conversation is really incomplete, absent more discussion of overall cost containment, quality and outcome measures, and a more fulsome understanding of non-claims-based payments. Fundamental questions have to be resolved before moving forward. Things like, what is the appropriate definition of primary care and behavioral health care? What primary care and behavioral care achieves better outcomes, and how will they be measured? Should Maine be setting overall spending targets that all parties come together to establish, like other states have done, for example, Massachusetts? How can Maine better accelerate the move to risk-based contracting? How much is being spent by carriers on primary care outside of claims-based fee-for-service payments? And should primary and behavioral health care spending include pharmacy costs or just medical? So states, as you've heard, that have considered these types of targets usually set them in the context of overall spending caps or global cost growth targets. There's good discussion of this in the Maine Quality Forum's 2021 annual report on primary care spending, which finds that the success of these approaches taken by other states is inconclusive and discusses the Rhode Island example that you've heard quite a bit about. We would caution the committee about moving forward with a proposal like this. Another caution about moving forward with a proposal like this is that primary care has experienced dramatic changes during COVID. And frankly, the provision of it is likely to never be the same as pre-pandemic. Our carriers have experienced greater than 1,000% increases in telehealth services, for example. And these are both for primary care and for behavioral health, as well as other services. So adaptations like this are underway and developing, and their overall impact is yet unknown. I've looked at the amendments proposed by the sponsor, and we're not clear exactly what's intended, and I am wrapping up. The notion that cost containment would be delayed for 4 years, is the intention really for medical costs to rise for 4 years because of additional investments in primary care? We don't think that's the right approach. What kind of mechanisms that are referred to in the amendment would ensure that the money that's allocated would go where it's intended? What's being thought of there? So while we don't support the passage of this bill as it's presented, we do want to keep primary and behavioral health care as central conversations in the state, and suggest that it might be appropriate to add them to the charge of an office for affordable health care, as proposed by LD 120. Thank you for your consideration. I'm happy to take any questions.
Are there questions for Ms. Pelletreau? All right, seeing none, we'll next move on to Ms. Ossenfort. Good morning still, go ahead.
Barely. Good morning, Senator Sanborn, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenfort. I represent Anthem Blue Cross and Blue Shield in South Portland, Maine, and I am here before you this morning to testify neither for nor against LD 1196. I'd also like to thank Representative Zager for reaching out to us and discussing the bill. It was a wonderful opportunity to understand what he's trying to achieve. And certainly we support the goal of increasing primary and behavioral health care. We do have some technical comments that I will submit to the committee in writing, but we wanted to touch upon a couple of points. One, we would suggest a statewide benchmark with annual targets that increase incrementally until 2026, rather than a carrier median. We would also, we have significant concerns about tying our approval of our rates to whether or not the benchmarks have been met. Our rates must be, cannot be inadequate, excessive, or unfairly discriminatory, and they must be actuarially sound. So regardless of whether we've been able to meet the targets, we still need adequate rates in order to ensure that we have the ability to pay claims. We are concerned about the requirement to meet targets by reducing avoidable spending without increasing spending overall. There are many factors that are not necessarily within our control that can impact overall spending, such as high cost drugs, provider consolidation and the associated rate increases, and new technologies. So with that, I am mindful of the fact that you have a very long day today. I'd be happy to answer any questions. And as I said, we will submit more detail in writing.
Thank you, Ms. Ossenfort. Are there questions for Ms. Ossenfort? right, seeing none. Next, we'll turn to Lisa Nolan.
Good morning, Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Lisa Nolan. I'm the Director of Value-Based Purchasing at the Healthcare Purchaser Alliance of Maine, and I'm here today to testify neither for nor against LD 1196. Our CEO, Peter Hayes, submitted a letter to the committee, but unfortunately he has a conflict this morning, so asked me to briefly summarize the Alliance's feedback. The Healthcare Purchaser Alliance is a nonprofit that represents the purchasers of healthcare in Maine. Our mission is to advance healthcare value and to support and incentivize high-quality, affordable care. We have over 50 members, including some of the largest public and private employers and health trusts in Maine. Collectively, our members spend over $1 billion annually providing healthcare for nearly 1/4 of the commercially insured population in the state. We agree with the bill's sponsor that high-quality primary care is the foundation of a robust healthcare system, and we have a long track record of supporting increased primary care investment. We also appreciate Representative Zager engaging us in discussions around this LD. But we're concerned that as currently drafted, LD 1196 could increase total healthcare spend for Maine employers and consumers. I'd note that I haven't seen the latest amendment put forward by the sponsor, so my comments don't reflect that update, and we look forward to reviewing any new cost management mechanisms now incorporated into the bill. We understand that the bill is based on similar program implemented in Rhode Island. An analysis of that program published in the journal Health Affairs found that increased primary care spending did not reduce total healthcare expenditures, nor did it reduce inpatient, outpatient, or specialty care utilization. Rather, the authors concluded that the reduction in healthcare spending that occurred in Rhode Island was due to price controls that were also implemented as part of Rhode Island's program, specifically price inflation caps and DRG-based payments for hospital inpatient care. In order to achieve the sponsor's objective of increasing primary care investment in a budget-neutral manner, the bill should consider specific mechanisms to manage and monitor overall costs, which were essential to the spending reductions that offset the increased primary care investment in Rhode Island. We also believe it's important that the effort include guardrails requiring that the additional primary care dollars be invested in a value-based manner that would improve quality and outcomes and potentially lower total costs. Without those components, it's likely that the bill will increase already unsustainable healthcare costs and further reduce affordability for employers and employees who are already struggling to pay for care. If employers and consumers are going to be asked to invest more in primary care, there should be a clear line of sight between that increased investment and the impact on healthcare quality, outcomes, and total spend. As LD 1196 is deliberated, we hope that the committee, the sponsor, and other stakeholders will consider mechanisms that allow for meaningful investment in primary care that do not further increase overall healthcare costs. Thank you for the opportunity to share the Healthcare Purchaser Alliance's feedback. I'd be happy to answer any questions.
Thank you, Ms. Nolan. Are there any questions for Ms. Nolan? All right, seeing none, we will turn to Kimberly Cook. Good afternoon, Ms. Cook, go ahead.
Good afternoon, Senator Sanborn and honorable members of the committee. I'm Kim Cook, and I'm here on behalf of Community Health Options, testifying neither for nor against the bill as drafted. As you're familiar, Community Health Options is Maine's only nonprofit co-op health insurance company. We're based in Lewiston and provide health insurance in the individual, small group, large group markets, as well as providing health plan administration for self-funded plans. And we exist for the benefit of our members and our mission, which is to provide affordable, high-quality benefits that promote health and well-being. We wholly support an enhanced focus on primary care, and we are a fervent believer in the critical role that primary care serves in our collective efforts to improve health outcomes while lowering the total cost of care. We commend Representative Zager for bringing this important issue to the forefront and very much appreciate his willingness to talk with us and many other stakeholders about healthcare reform and this bill. LD 1196 is laudable in its efforts to right the imbalance that currently exists within our healthcare system that has inadequately compensated primary care. And we believe primary care is the best engine that we have to drive towards the triple aim of improving the patient experience of care, including quality and satisfaction, improving the health of the population, and reducing per capita cost of healthcare. The imbalance that exists perpetuates the fee-for-service hamster wheel that you've heard mentioned that Maine has held on to for far too long. However, we're concerned that applying more money to a broken fee-for-service model won't solve the problem. Primary care providers are largely employed in Maine, and the predominant employers are the four health systems. Paying more for primary care does not ensure that the primary care providers will either gain in compensation or result in a change from volume to value. I think everyone on the committee would agree that in total, there is more than sufficient amounts of money applied in healthcare today. I think Representative Zager brought some of those statistics forward with looking at comparisons to other countries. The issue is how funds are being allocated and used for care. Unless the fundamental problems of a fee-for-service discount structure are addressed, paying more for primary care will simply result in paying more without the additional cost showing up, and with the additional cost showing up in higher premiums. We agree with Representative Zager that the status quo is not an option and would wholeheartedly support continued work on this bill and would gladly participate in any work group that the sponsor or the committee chooses if you choose that approach. Thank you for the consideration of our comments today. I'll be happy to answer any questions. We'll be submitting written testimony, which also refers back to the primary care study commission that the legislature in 2007 commissioned. That was the 123rd. I had the privilege of monitoring that back then. It'd be interesting for you all to potentially look at how that's been implemented and what impacts that had as well. Thank you.
Thank you. Thank you, Ms. Cook. Are there questions for Ms. Cook? All right, seeing none, we'll next hear from Superintendent Chapa. Good afternoon, Superintendent. Go ahead.
Good afternoon, Senator Sanborn, members of the committee. I am Superintendent of Insurance Eric Chapa, and I'm here today to testify neither for nor against LD 1160. First of all, I'd like to thank Representative Zager for reaching out and engaging in discussions with us. And I acknowledge my testimony largely relates to the bill as written, and he has graciously agreed to work on these items. I'll skip over the part of my testimony that relates to what the bill does, because 2 hours into it, the committee is well aware of that. First, the bill does not currently approve large group rates as would be required by the bill. We are not aware of any other state that requires a review of large group rates and are concerned that this requirement would make Maine an outlier. Next, year-end claims data is not finalized by the carriers until spring of the following year. We do not know when this data is finalized for Maine Care. As the bill is written, the Bureau would be required to calculate spending targets in the weeks before carriers file their next year plans and to assess compliance with those targets based on data for the plan year that is still in progress. And finally, MACO worked diligently over a year to determine which CPT codes should be included in determining primary care spend. We do not know if determining CPT codes to include in the behavioral health bucket would require the same diligence and time. With that, I'd like to thank you and be glad to answer any questions now at the work session.
Thank you, Superintendent. Representative Arford.
Yeah, thank you very much, Madam Chair, and thank you, Superintendent, for being with us. Quick question. I want to make sure I understand what percentage of our covered lives the state will, well, this legislation, if passed, would impact. Because it's my understanding that we do not regulate any of the funds that are regulated by the federal government, including all the ERISA plans, all the self-funded plans, all the Medicare plans, the VA plans. So what percentage would this impact?
Maine regulates fully insured about 23 to between 23 and 25% of the Maine population. So that's about a little over 300,000.
So again, I don't want to belabor this point, but I'm trying to get a vision of how this would work if only that percentage of covered lives, in other words, people in this state, they were actually, that the way in which their health care was paid for changed as dictated by this legislation. And the rest of the population, the way in which their health care was being paid for did not change, or would it change? I'm just trying to get a sense of that.
That's a legitimate question. I think you'd have to ask the sponsor. I mean, we can only control the population that is subject to my office's regulation. Obviously, we can't control Medicare, Medicare, or ERISA plans.
Okay,
so
thank
I really can't answer that question.
Thank you.
Are there additional questions for the superintendent? Someone else has their hand up, but I don't see it. Well, hang on just a moment. Oh, it's an attendee. Okay. We're not going to hear again from the sponsor at this time, but those are certainly conversations that can come after the public hearing. Okay. Seeing no further questions for the superintendent, I am going to give a last call. If there's anyone on the call who wished to be heard verbally and hasn't had the chance to do so yet with regard to this bill, please raise your hand at this time. Seeing no hands go up, I'm going to close the hearing on LD 1196, and a work session will be scheduled probably for the week after next on this bill. The plan for the next bit here is that we are going to pick up LD 1341 next, and then we'll do LD 1293. These are both much shorter testimony lists than the bill we just concluded. I need to give about a 5-minute break here before we start with that, since we've been going for over 2 hours now. So let's convene back here at 12:13, and we will pick up LD 1341 at that time. Thanks, everybody. Okay, it is 12:13. Trying to keep us running here so that we can get through all of the work that we have in front of us. If you can pop your camera on to let me know that you're back from our short break, that'll be great. Okay, just wait for a couple more faces to appear. I suspect there's some more people within the sound of my voice here. Okay, great. We are going to now open a hearing on LD 1341, an act to protect Medicare beneficiaries from surprise medical billing. And the bill is going to be presented by Representative Art Bell. Welcome to our committee, Representative Bell. Please go ahead.
Good afternoon. Good afternoon, Chair Sanborn, and I don't see my friend Tepler, Representative Tepler, and distinguished members of the Health Coverage, Insurance, and Financial Services Committee. My name is Art Bell, and I represent House District 47, which comprises Yarmouth, Chesapeake, and Long Island. I come before you today to introduce LD 1341, an act to protect Medicare beneficiaries from surprise medical billings. Nationally, nearly 96% of medical care providers accept Medicare assignments and thus agree to the program's payment terms. However, often in the case of an emergency, when an enrollee receives emergency care at a facility that is out of network, a patient is subject to surprise billing when the patient is billed for the difference between the provider's charge and what the insurance pays. Several states, including 4 of our neighboring states, have adopted MOM laws, MOM, Medicare Overcharge Measure laws, to address excess charges. As you will see with the testimony of my constituent that follows, these laws enable elderly Medicare enrollees to choose lower cost plans without worrying that they will be exposed to surprise excess charges in the case of an emergency. Maine should do the same to protect its elderly Medicare beneficiaries. My constituent, Anna Lazar, will be following me and will explain in detail her experience. Thank you.
Thank you, Representative Bell. Are there questions for the sponsor? That was very nicely done, Christian. Thank you for reminding me. I was muted without having to say the words. All right. Seeing none, we'll next go on to Anna Lazar.
Hello.
Good afternoon. We can hear you. We can't see you. You're welcome to start your video if you'd like, or you can just proceed.
Okay.
There you are. Go.
Thank you, members of the committee. I'm a retired faculty member of the Humane System, and after teaching for 43 years, and I'm here today to support LD 1341. Just tell me my story. Upon retiring, I took the university's group insurance plan. And then about a year later, the university made a decision to drop the insurance plan and to requiring retirees to look on the open market. I began to look, and I looked at the options open to me, Medicare, and specifically Medicare supplement plans. And what I found was that both the Plan N and a Plan G provided basically the same service and protections, but Plan N would cost my husband and I $1,000 less a year. when I proposed to my retiree humane Facebook group that folks might want to consider a Plan N instead of a much more expensive Plan G, people said, no, the risk is too high because Plan N does not cover excess charges. So I decided to look and see what those excess charges were. And basically what I discovered is that while the term excess charges is a very scary term, as it should be for anyone living on a fixed income, that in fact the excess charges are rare indeed. No hospitals charge them, and nationwide about 96% of physicians simply accept Medicare assignment, which means if you accept Medicare assignment, you take Medicare's rate. So as I discovered that the excess charges really are a very minor risk that a person taking a Plan N would almost never see, yet the retiree who looks at these two plans is frightened by those terms. Excess charges, very scary. Just to explain to you why physicians don't charge excess charges, Medicare sets up a number of disincentives. A physician who wishes to charge above the Medicare rate, that is capped. They also are paid less for the service, and Medicare does not permit them to bill directly. So they have to collect upfront from the patient or chase the patient down. So for this reason, it's really a rare occurrence. Yet the term is so frightening that people will not choose a plan that is comparable, but looks to have greater risk. When I investigated a bit further, I found that there are 8 states in the country that do not permit excess charges. 4 of those states happen to be our neighbors: Connecticut, Rhode Island, Massachusetts, and Vermont. It's only Maine and New Hampshire that permit excess charges. And so I contacted my representatives requesting a bill that would do the same here in Maine. This is no cost to the state of Maine. It simply eliminates what I see as terminology that is terribly frightening, that causes Medicare beneficiaries to choose a plan that's more expensive to them for fear of a risk incurred. So that's my testimony today. I think the word surprise charges is a good one. It's also called excess, as I said, excess charges. And if you are a retiree and you happen to live over the border, you live in Massachusetts, you can freely choose a Plan N without worrying that you are going to be hit at some time with some excess charge that was unpredictable. I really think it's more than anything, it's an elimination of a terminology that scares people from keeping more money essentially in the state of Maine and in their pockets. And with that, I thank you for your time and attention. And I certainly am open to answering any questions. The other states, by the way.
Thank you, Ms. Lazar.
Yeah. Ohio, Minnesota, New York, and Pennsylvania.
Thank you. Are there questions for Ms. Lazar? All right. Seeing none, thank you for joining us today. Are there additional folks in our Zoom call who wish to testify in favor of the bill? Seeing no hands raised, we'll turn to those who are testifying in opposition to the bill, and we'll start with Jeff Austin.
Good morning, Senator Sanborn, members of the committee. My name is Jeff Austin, here to speak on in opposition to the bill, although I have to admit I'm more confused than I am clear on the issue. Our first concern is you need to distinguish sort of in participating providers or in-network providers from non-participating providers. Most of our members participate in Medicare. Our concern with the bill is it looks like it could potentially be interpreted to mean we can't collect Medicare's copays and deductibles. I mean, Medicare pays a portion of the bill, and then you collect some of it from the patient. I'm looking at the bill, they define balance bill oddly. They don't reference the Medicare rate. They reference another amount, a reasonable charge. We just don't want to lose the ability to collect the copays and deductibles that Medicare imposes. I'm also a little, you should also be clear about whether this is applying to participating providers or out of network or non-participating providers. And just further orientation, you're in Title 32. This is the licensing statutes. I mean, this is presumably the Board of Licensing that's going to be enforcing this. It doesn't even sit on top of the hospital facility fee. It's just going after the physician. So I'm a little bit more confused than anything else. I know there are different Medicare Advantage plans, some of which have balanced billing protections and some of which don't. I guess as a final comment, you do pass laws that impact Medicare patients, like, billing estimates. You can pass a law saying, hey, hospitals, give everyone in Maine a billing estimate, including Medicare. But a Medicare only bill dealing with what's paid, I'm not sure how far you can do that. It's a novel question to me. I've not seen a bill like this before that regulates payment in Medicare and Medicare only. So the proponent said there's some other states. I'd be interested to see the other state statutes, but we just want to make sure we can collect Medicare's imposed copays and deductibles for in-network providers. So with that, I'll wrap up my testimony and take any questions.
Thank you, Mr. Austin. I understand your questions and hope that they will be answered by some additional information on what's happened, because there's more than a handful of other states that have these laws.
Okay.
Are there other questions for Mr. Austin? All right, seeing none, thanks for joining us today. Next, we will hear from Elizabeth Frazier.
Don't see Elizabeth on the call.
Okay, is Ann Robinson on the call?
Yep.
Yep, I would think she might want to testify. She represents the same organization. Good afternoon, Ms. Robinson.
Good afternoon, Senator Sanborn. Representative Tepler, I'm not sure if she's there, sorry, members of the committee, Ann Robinson on behalf of Spectrum Healthcare Partners. Actually, I did submit written testimony, and so I don't have a lot more to add to that. I mean, I share, I guess, the confusion in part that Mr. Austin expressed. I read the bill essentially as just a blanket approach, I guess, to Medicare billing. And as we pointed out, I mean, Medicare speaks largely, sets out exactly how participating and non-participating providers can bill, has limitations that are applicable to those. I walked through a hypothetical example of what that would be in the event that you had a participating or a non-participating provider. So from our perspective, the legislation is both unnecessary and would conflict with Medicare law, although there are still the open questions that Jeff outlined. So I don't really have a lot more to add than what I have in my written testimony. Frankly, hadn't even planned to testify today. So.
Okay.
But if you have any questions about that example, that I went through, I'd be happy to answer those.
Okay. Are there any questions for Ms. Robinson? All right. I think we're going to need to do some work to figure out what these other states are doing and what words they're using to regulate this particular issue. All right. There is no one else signed up to testify verbally for or against this bill or NFNA and this particular hearing. So if you wanted to testify orally today in this hearing, please raise your hand at this time. Seeing none, we will close the hearing. It will be scheduled for a work session in the coming days. And next I'm looking for Ned Claxton. I don't see Senator Claxton yet in our meeting, but Christian, I don't know if you want to text him and see if he can join. And if not, I think Senator Brenner is prepared to present the bill for him. We'll just give it a minute. All right, I know that Senator Claxton was running hearings this morning in the Health and Human Services Committee, which has even more on its plate than we do. So he may well still be tied up in that. He had a pretty controversial hearing scheduled for this morning. So Christian, unless you've heard from him that he's on his way, let's see. All right. We will, I think, have Senator Brenner present. He did know that that was a possibility this morning. So yeah, Senator Brenner, why don't you go ahead?
All right. Senator Sanborn, Representative Tepler, and distinguished members of the Health Coverage, Insurance, and Financial Services Committee. I'm Stacy Brenner, and I'm speaking on behalf of Senator Ned Claxton, who represents Senate District 20, which includes Auburn, Poland, Minot, Mechanic Falls, and New Gloucester. Thank you for the opportunity to present LD 1293, an act to improve access to certain injectable medications for treatment of mental illness and substance use disorder. The intent of this bill is to help lower some of the barriers experienced by those with significant mental illness as they work to stabilize their lives. By giving these folks an alternative way to get the medications that they need, we would be helping to promote better mental health. Science has created some amazing medicines with the ability to help stabilize a person's mental health if they are plagued by disordered thinking or addiction. At this point, there are about a dozen medicines that help with substance use disorder or severe mental illness and can be administered by injection. These medicines being administered would have been prescribed by a provider who knows the patient and with whom a good working relationship and a good pharmacy regime have been established. Once it is clear that a given program of medicines are working as intended, the responsibility for administering the medications could be transferred to a pharmacist. This could be done by a specific prescription or by a collaborative practice agreement. Imagine if you were often distracted by intrusive thoughts or had struggled to continue your recovery. How much energy would you have to call a provider's office, work out a time to come in, remember the appointment, and then get to the appointment? You might also have to make arrangements for a ride, finding someone willing to wait for you while you got your shot. For most of us, this is not a big challenge, and we only need to do it infrequently. For too many of us, this is simply too much to reliably manage week after week, month after month, depending on how often you need your injection of medicine. Being able to go to your local pharmacy to get your injection makes the whole process easier. It means you don't need to call and schedule your appointment, and you might be able to just show up It means you can go on a weekend day and not have to work around your job that you're struggling to already hold down. It means you can go to a place where you might also be shopping. This bill permits pharmacists licensed within the state to administer to adults injections of drugs approved by the FDA for the treatment of mental illness and substance use disorder upon the order of a licensed practitioner or as part of a collaborative practice agreement. Many other states permit this option, and it is supported by many pharmacy chains and pharmacists. It represents an effort to further chip away at barriers to care for an individual by improving access to that care. Doing so could be enormously helpful to those who would benefit from this option. For a modest expense, we can help those who are working hard to maintain their opioid-free status or to find some reliable mental health. I ask for your support of this bill.
Thank you, Senator Brenner.
Gonna take questions.
And I'm not going to ask you to, but Senator Claxton has joined us, so we're going to pull him into the committee room.
Perfect.
We're going to let him know that you have read his testimony. I'm going to wait until he can hear me. So Senator Brenner has just read your testimony, Senator Claxton, and I just wanted to give you the opportunity to either add anything or take questions from the committee.
First, I'll thank Senator Brenner for a presentation that was arguably much better than mine would have been. And I'll just point out that this is a well-established system in a lot of pharmacies that originated from the Midwest about 8 years ago and has significantly improved access for people who need the benefit of that flexibility and that option. That's all I really need to add.
Thank you, Senator Claxton. Representative Matheson, go ahead.
Thank you, Madam Chair. Hello, Senator Claxton. Nice to see you.
Hello.
Just curious, is there a reason why you narrowed it to just those injectables and not all FDA approved injectable medications?
The pharmacists already have permission to do immunization injections, and I'm an incrementalist. I thought we would start and make sure this system worked for the people who are really crucially needed it at a time when our mental health system is being stretched because so many people are suffering emotionally. And then once it's on the books, it's there as an option to expand, which is a different process than getting it established. That was a philosophical decision, not a medically based one.
Thank you.
Thanks, Representative Arford.
Thank you, Madam Chair, and thank you, Representative Claxton for being, Senator Claxton for being with us. I have already been convinced that this is a very worthy piece of legislation because it was my understanding that we acted to allow for this in the pharmacy bill, and I don't have the number in front of me, that we passed a week or two ago. I don't know the date that we passed that bill, that by changing the name of the allowing pharmacists to be one of the healthcare provider, one of the services they would now be able to deliver would be the injectables.
I'm not sure how to answer that because I wasn't at that hearing and I didn't hear that bill. All I know is that this is, we've been working with the Department of Pharmacy Licensing. And so it falls under that board.
Okay, right. So that's the next step to the bill we passed. Is that the way it works?
You'd have to, there would be rules generated, yes.
Okay, great. Well, thank you so much for bringing this bill forward.
Yeah. Okay. And Representative Arford, I can help sort of connect the dots offline on that piece. Are there additional questions? All right, I will just add one, Senator Claxton. I would love if we could consider a little bit more of an increment on this bill. And so I guess I would ask whether you think that administration of HIV prevention medications that will be available by injection next year would be the type of thing that should also fall under this permission in the interest of public health.
I would consider that a friendly amendment.
All right. So I'm just sort of planting that seed for folks to think about because of the public health implications of it. It's not on the market yet, so it's a bit of a future proofing in our legislation, but it is also something that would really have massive impact on public health. Thank you for your indulgence, Senator. Are there other questions for the Senator? All right, seeing none, thanks for bringing us this bill and for your magic appearance just in the nick of time.
Sorry, I couldn't get here quicker. Thank you for the
We'll
opportunity.
send you back through the wormhole to your committee. All right, with that, let's next hear from those speaking in favor of the bill. And we will continue using the 3-minute clock, and I will call on Courtney Allen.
I don't see Courtney on the call.
Okay, I'll call on Amelia Arnold. Good afternoon, Ms. Arnold, go ahead.
Good afternoon. I submitted some written testimony, but I'll keep my comments brief because I know you've had a long day and we've discussed pharmacy issues in the past. So I'm Amelia Arnold and I'm here today for the Maine Pharmacy Association. And I'll just highlight that pharmacists are very well trained in order to be able to do this. We represent a place that patients can access care. This bill allows for the administration of injectable medications in 2 scenarios as was presented, which the first would be when a prescriber specifically requests that it's administered by a pharmacist, and the next is via a collaborative drug therapy management agreement. So it's not that we could just decide to do this on our own without the request, and we do have to report the administration back to close that healthcare loop. So I would just highlight that. One thing I would say is I would be very supportive of an amendment for the reasons listed of having it be all FDA approved medications with the intention of we could do injectable birth control medications and any future releases that we may not know are coming or we may have an idea of, such as HIV PrEP releases. So I would just suggest that perhaps opening the door a little wider. We've been administering immunizations in Maine for over 10 years now, and we're very well suited to do this. So with that, I will turn it back over and answer any questions.
Thank you very much, Ms. Arnold. Are there any questions for Dr. Arnold, I think, right?
Thank you.
Yeah. Are there questions for Dr. Arnold? All right, seeing none. Next, we will turn to Eleanor Dudek, although I don't see her on the call.
I don't think she's with us.
In which case, we'll turn to Curtis Picard.
Good afternoon, Senator Sanborn and members of the Health Coverage, Insurance, and Financial Services Committee. I am Curtis Picard, President and CEO of the Retail Association of Maine, here to speak in favor of LD 1293. I did submit written testimony, so I won't read that for you today. We absolutely support the bill. Dr. Arnold did a great job, as did Senator Claxton, who we greatly appreciate submitting the bill as well. We support the friendly amendment as well. I know you guys have a long day, have had a long day, and will have a long day. So I'll stop there and I'm happy to answer any questions.
Thank you very much, Mr. Picard. Are there questions for Mr. Picard? All right, seeing none, we'll move on to Mallory Shaughnessy. Good afternoon, Ms. Shaughnessy. Welcome back. Go ahead.
Good afternoon, Senator Sanborn. And I don't believe we have Representative Tepler, but members of the Joint Committee on Health Coverage, Insurance, and Financial Services. I am Mallory Shaughnessy, a resident of Westbrook and the Executive Director of the Alliance for Addiction and Mental Health Services. And this testimony is on behalf of the Alliance in support of LD 1293. This bill does take, as I think was mentioned, the next step to allow pharmacists licensed within the state to administer medications such as long-acting injectable drugs, or LAIs, approved by the United States Food and Drug Administration for the treatment of mental illness and substance use disorder. Long-acting injectable drugs are a major strategy to care for many behavioral health conditions. Increased adherence and the convenience of taking medication only once a month makes a difference for many patients. And there are far fewer mental health clinics around the state than there are pharmacies, so this makes it easier for access. I'm not going to read all of my testimony. You've been hearing what this would do. You had a testimonies a week ago on this issue, but we just feel that it's a really good movement forward and allowing access. So I'd love to answer any questions if you have any, but please note that we think this would be a great way to go.
Thank you, Ms. Shaughnessy. Are there any questions for Ms. Shaughnessy? All right, seeing none, the next person on my list also doesn't appear to be in the meeting, Linda Sillars.
I believe that's the person calling it.
Oh, okay, great. We can hear from her. Good afternoon. Go ahead and unmute yourself and we can hear from you. You are still muted, so we can't hear you yet. And I'm not sure what to tell you about how to unmute on a phone. I don't know how to do that. But we can't hear you at this time. Christian, do you have any advice?
It's something like a *6 combination you have to type in.
Okay, *6 should make it possible to unmute. Representative Quinn?
If *6 doesn't work, then try *9. But yes,
*6 worked. Great.
Okay, good.
Go ahead. Thank you.
You can hear me now?
We sure can. Yes, please.
Oh, good.
Provide your testimony.
Good. Good afternoon, senators and members of the committee. I'm an adult psychiatric nurse practitioner. I have been one for 15 years. I've been in psychiatry for 40 as a therapist and as a head nurse of inpatient units. I submitted a testimony. I won't repeat myself. It's just that I'm totally support this bill. I've been in the trenches. I was on an ACT team for 4 years, and one of the main problems was trying to get the injections into the patient. When people are that disorganized, they can't remember their appointments. They can't remember the day they're supposed to get their injection. Sometimes we'd have a community search for these people because them not getting their injections meant they'd either be in the hospital, be in jail, or homeless. I mean, that's the kind of situation you're dealing with a seriously and chronically mentally ill patient. So you can see it's a life-saving support to have it very easily attainable for these people to get their meds.
Great. Thank you for providing that testimony and for being with us today. Are there questions for Dr. Sillars? All right. Seeing none, I don't have anyone else signed up to testify verbally on this bill. If you did wish to testify on this bill, please raise your hand. Mr. Moran. Go ahead, Mr. Moran. We'll bring you in. Go ahead, Mr. Moran.
Members of the committee, Representative Tepler, if you're there, and I'm happy to be testifying in support of the bill with just a suggested amendment. I first want to recognize that Dr. Arnold, Curtis, Ms. Kate Knox met with Andy McLean and I about this previously. We greatly appreciated that. I absolutely love that, and we had a great discussion. After taking this bill back to our membership, they supported it. It's a great move. Increasing access to these medications is outstanding, but some of our members talked about maybe possibly offering an amendment, a qualified amendment with our support to offer that the initial dose not be given in a pharmacy setting. Specific examples included medication-assisted treatment, which I'm sure you're all well familiar with because of our opioid epidemic. The standard of care for that is that it be combined with counseling as part of a comprehensive treatment plan. It's contraindicated in those currently receiving or taking opioids. A patient has to be opioid free for 7 to 10 days before taking that initial injection. There could be serious health consequences and also severe and serious withdrawal after the fact if the wrong person gets an injection of Vivitrol when they're actively on opioids. As far as antipsychotics are concerned, there are health systems throughout the state that do this at their walk-in clinics, but they only do maintenance for the patients, no first timers. And they always have a specifically trained provider, whether it be advanced practice or a physician available during the times that they administer that medication in case there are questions, as not very many providers routinely use these medications. So we're all for it, but how about we work with the primary care medical home model to start off that first injection and then work with the collaboration and the standing order at the pharmacy settings. I'd be happy to take any questions and provide any information before. And by the way, the HIV amendment, I can, even if I get in trouble for this, I'm going to make a commitment that we will support that right away with the same amendment.
Thank you, Mr. Moran. Senator Brenner, go ahead.
Thank you, Madam Chair. Good afternoon, Mr. Moran. It's nice to see you.
Hi, my own senator from Scarborough and Gorham.
That's right. I'm wondering if you could speak a little bit more to the medication-assisted support for substance use disorder. Which medication are you talking about?
Vivitrol. That's the long-acting medication-assisted treatment.
Okay, but
normally taken orally first, I think, also.
Okay, but for something more like a Suboxone injectable, you would be amenable to that?
Yeah, I mean, I'd have to go back, but I mean, I guess this could be done through rules because the bill offers rules too. We just want to, I mean, rules are a lot tougher to do because it's a different licensing board. And, you know, this is an environment where we have legislators making statutory requirements that then allow guardrails and parameters for licensing boards. And since there aren't physicians on that board, like our members, we'd prefer those guardrails to be in statute. But as far as Suboxone, I was only given the Vivitrol example, so somebody smarter than I and more clinically knowledgeable than I on the Suboxone issue. It would be hard to just put a specific drug in statute though, so that's why I was thinking just make it for maintenance after the first and move on from there, and that way we cover all of them. And then like Senator Claxton said, incrementally, if we want to come back later and do that, then that's fine, or through rules.
If I'm not mistaken, I'm pretty sure that Suboxone is a medication that you can give in the ER when someone shows up that has a substance use disorder. So it doesn't require a delay in use from opioids, and it's incredibly effective. So I just would hope that you might reconsider the category and maybe be more specific.
Absolutely, I can take that back, but I'm certainly not going to question what you're saying. I'm just providing the information I was given by our substance use expert physicians.
Great.
So thank you, though.
Thanks, Mr. Moran.
Mr. Moran, I'd love you to take back also just a clarification that this particular statute or bill would require that the order of a practitioner in order for any dose, whether it was a maintenance dose or an initial dose, to be given in a pharmacy setting. So I'd love it if you'd go back to your membership and just say, hey, don't you guys want to be the ones in charge about whether the initial dose is covered by this bill or not? I would personally rather leave the decision up to the practitioner. So this bill is more doctor friendly than what you just proposed, which wouldn't allow a doctor to ask a pharmacist to be involved in the initial dose. So I think sometimes first injections might well be at the pharmacy, particularly if the prescriber gives the oral dose of the Vivitrol first. So in any case, it would be up to the practitioner under this bill. So I'd just love it if you would take that back to your membership and point out the sort of doctor-centric nature of the language.
Yeah, absolutely. And That's part of the
ahead,
process,
Dan.
and I struggled with that too in reading the bill. So Senator Sanborn, you were thinking exactly what I was thinking. So I'm the messenger, and I can certainly work on that between now and the work session. And if that's the way they want to go, then absolutely.
Okay, Representative Quint, go ahead.
Thank you so much. This actually brings up the question that I had with the prior bill, with the pharmacists being healthcare workers, that in a small rural pharmacy, perhaps a doctor's order would say that the pharmacist could give something like Suboxone. And if someone came in crisis, this could be a safety issue. So I was just wondering if there was any, feedback on the way that would work. Once again, a rural community that may have a pharmacist and maybe one assistant, that's two people in there in a crisis situation, how doctors would do that. So the initial dose, I could understand where they were coming from with that, and obviously you would want the doctor to do that. The physician has the authority to opt out of having to do this. Thank you.
Yeah, absolutely. And the more I'm listening to this is I'm gonna, this is team-based legislating. This is your bill, and I'll work with the experts within our organization and the experts such as you, Representative Quinn and Senator Brenner. And I'm certain that this won't be a problem.
Thank you for your testimony. Are there any other questions for Mr. Moran? All right, and seeing no other hands went up when I called last call on this hearing, I will close the hearing on LD 1293. That completes our morning scheduled work sessions. Pardon me. That completes our morning scheduled work sessions, and our plan is to caucus at lunch. We do have another public hearing on LD 1320 that is noticed for 1:30, and then one for LD 1347. The sponsor of that bill has let me know that he is going to ask us to vote on not to pass on it. So that will be a very brief hearing, followed by a very brief work session, I would imagine. So that's what we have in front of us. I'm going to suggest that we take a 1 hour break from now until 1:55, which is when our first work session of the afternoon is actually noticed for. But we will start at 1:55 with the public hearings. That should go very quickly, and then we'll roll straight into the work sessions. So for my caucus, I will be sending out a link immediately after this. We'll take about 5 minutes to get our lunch, and then we'll meet. Representative Morris?
Yes, I will send out a link immediately as well.
Great. Thanks, everybody. Okay, sorry for the delay, everyone. If folks are there, please turn on your camera so we know. I apologize for the delay. We have not had one of those extra 20 minutes sort of caucuses in a while, so I apologize for keeping folks waiting in the Zoom universe. We'll just wait for some more folks to be able to jump back into our Zoom call. And just as a reminder, we are going to start with, oh, I probably haven't prepared for this as well, because it looks like Representative Tepler isn't going to be joining us this afternoon, and the first bill is mine. So Senator Brenner, I'm going to ask you to preside for a moment while we get the first public hearing underway, if you don't mind.
Okay. We are, hold on, let me just get myself.
Yeah, I apologize. I didn't bring this on you until just now. So it just occurred to me.
It was mentioned yesterday. I'm almost there.
Okay.
All right, so welcome back to the Health Coverage Insurance and Financial Services Committee. We're going to open up a public hearing for LD 1320, and we'll turn to our own Senator Sanborn to introduce the bill.
Thank you, Senator Brenner. So Senator Brenner and other honorable colleagues of the committee, I am here to introduce LD 1320, an act to allow main shareholders of banks and members and corporators of credit unions to hold virtual meetings. When the pandemic hit our state last spring, many of us found ourselves working remotely and adapting to our typical in-person activities to Zoom. Throughout the pandemic, this necessity to change the way we live has revealed various outdated policies and laws that are currently on the books. One of these issues that was discovered was that Maine statute provides banks and credit unions with little flexibility on how they can hold their key meetings. This meant that under Maine law, they were not allowed to hold these meetings virtually. This bill seeks to address that issue and make a simple fix, allowing these financial institutions the ability to hold shareholder, mutual member, and other key meetings remotely. The bill will update the law to the 21st century standards and allow them the flexibility to operate in the post-pandemic world. Thank you for your time. I'd be happy to answer any questions that you might have.
Thank you, Senator Sanborn. Are there any questions for the sponsor? All right, not seeing any. Thanks for introducing the bill. And I will look into the attendee space. And if there's anyone here to speak in favor of the bill, if you could raise your hand. We'll bring in Gretchen Jones and then Kate Pinot. Welcome, Ms. Jones.
Thank you very much. Good afternoon, Senator Sanborn, Senator Brenner, members of the committee. My name is Gretchen Jones. I live in Brunswick. I'm an attorney with the law firm of Eaton Peabody, and I am here today representing the Maine Bankers Association in support of LD 1320 as amended by the sponsor's amendment. I have submitted written testimony together with a memo that explains in detail why Maine financial institutions need this bill. As explained in my memo, the Maine Banking Code requires that the constituencies of Maine banks hold meetings on an annual basis to elect directors, requires that those meetings be held at a specific place, and also requires in-person attendance at those meetings. And as you can imagine, those requirements created some compliance challenges for our banks during the pandemic. And as Senator Sanborn noted, given advancements in technology, they're not really necessary anymore. LD 1320 allows these annual meetings to be held remotely. And it also permits remote participation in these meetings, again, as Senator Sanborn noted, bringing the law into the 21st century. That's it in a nutshell. Thank you, Senator Sanborn, for sponsoring this bill. Thank you for the opportunity to testify. I'm happy to answer any questions and to provide any additional information you may require.
Thank you, Ms. Jones. Are there any questions from the committee? All right, not seeing any. We appreciate
That was easy. Thank you.
And next up would be Kate Pinot. Did we lose her in the wormhole? Oh, here we go. Welcome.
Senator Brenner, members of the committee. I am not Kate Pinot. I am the staffer for her that works in the same office. She's tied up on another hearing. For those of you who know, I am Ed Pino, a representative of Vassalboro, and I represent the Maine Credit Union League today. Just a note, it's interesting that when I first started representing the credit unions, Gretchen Jones was actually the vice president that gave me my marching orders. So it's kind of interesting that that rabbit has run that circle. The Maine Credit Union League, as you folks know, is non-for-profit. We have over 725,000 members. One of the things Senator Sanborn's bill does for us, it really alleviates the issues that COVID-19 and the pandemic caused, but it also brings us, as Gretchen said, into the 21st century. We think it's going to allow more participation in our meetings from the hinterlands of the state of Maine. So we find that's really helpful. We'd also like to say that working on the amended language that was submitted by the sponsor, we worked with the Bureau of Financial Institutions and also with Maine Bankers Association. I know you folks have had an awful long week, and I can go on. There's written testimony there, and I know you have the amendment in front of you. If you have any questions, I'm more than happy to answer them.
Thank you, Mr. Pinot. We're grateful for your brevity. Any questions from the committee? All right, thank you so much.
Thank you.
And moving on, we have Gordon Larendow. Hopefully I said that correctly. Welcome. Have I pronounced your name correctly?
Yes, you did. Thank you.
Welcome. Thanks for joining us.
Thank you. Senator Sanborn, Senator Brenner, and members of the committee, my name is Gordon Larendow. I'm the attorney with the Maine Bureau of Financial Institutions. I'm here to testify in support of LD 1320, the amended version, an act to allow Maine shareholders of banks and members incorporated of credit unions to hold virtual meetings. I submitted written testimony to the committee that I will also not read. The Bankers Association and the Credit Union League raised some of the points that I had hoped to make in my testimony as well. And I just want to indicate to the committee that we had the opportunity to work with both the Bankers Association and the League in developing language for the amended version of the bill. With that, thank you for allowing me to appear before you today, and I'm happy to answer any questions.
Are there any questions for Mr. Larendow? All right, not seeing any. Thanks for joining us.
Thank you.
That's all that I see signed up to offer testimony, but if you're in the attendee space and you're here to speak either for the legislation, in opposition to the legislation, or neither for nor against, you could raise your hand and we'll bring you over. All right, not seeing anyone. I will close the public hearing on 1320.
Thanks so much, Senator Brenner. I appreciate your jumping in for us. And I will, Mr. Larendow just came back the wrong way through the wormhole. We'll send him back again. So we are next going to turn to LD 1347, and I will invite Senate President Jackson to present to us.
Made it.
Good afternoon. Go ahead.
Senator Sanborn, members of the Joint Standing Committee of Health Coverage, Insurance, Financial Services. I am Senator Troy Jackson. I represent Senate District 1 in Northern Mercer County, and I'm here to present LD 1347, an act to clarify that commercial service contracts are excluded from Service Contracts Act. And I have, like, this one of the best bills I've ever been a part of. I have some great testimony. I think I can turn everyone in opposition to this bill today, but I've decided to ask the committee to kill the bill for another time. But more than anything, I know you've had a long week, and I appreciate all the work the committee's done. Like I said, I'd ask all not to pass on this.
Thank you, Senator Jackson. So in light of Senate President Jackson's request that we vote not to pass on the bill, I would give an opportunity for anyone who is here who wishes to give oral testimony anyway to raise their hands before I close the public hearing. Not seeing anyone, thankfully. I will close the public hearing on LD 1347, and we appreciate your brevity and your assistance in disposing of one of the 100 bills we need to vote on by what, 2 weeks from now. Thank you, Senate President Jackson, and we'll see you soon. All right. So that concludes the public hearings that we needed to get through today. I'm going to suggest that we move directly to work session on LD 1347 while it's fresh in our minds. And I would move ought not to pass. Senator Brenner has seconded, and I'll ask the clerk to call the roll. I caught him off guard.
I have 2 mutes. I was confused. Representative Quint. Well,
I'm off guard too. Can you give me a second?
sure. Representative.
This is Senate President Jackson's bill that we just heard.
Representative Connor is absent. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Oops, sorry, yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler is absent. Senator Sanborn.
Yes.
Senator Sanborn, yes. And now Representative Quint.
Now that I have the right number, know what I'm doing, it's also yes.
Representative Quint, yes. That is 10 yes, 3 absent.
Okay, great. 1 down, 99 to go. Okay, so next for this afternoon, I think we'll start by picking up the certificate of need bills. And so the way that I want to proceed on these is that we're going to sort of have a work session on all of the LDs that are about certificate of need. And then we would take motions and vote on each of the LDs individually at as we conclude the work session. So with that, I think, Colleen, I'll have you present your slide for us. And then I think we have also a member, someone from the department that I might ask to hear from briefly with what their sort of stance is on this, and
sure,
go from there.
Okay, great. I'll share my screen here. Let's see. I have to go back. Sorry. It's underneath. Oh, I just lost it. Here we go. You see that now?
Yep.
Okay. It was underneath my bar at the top, so I had to move things around a little. So what I did for purposes of, as Senator Sanborn said, there are 5 bills that you had public hearings on last week that proposed to make changes to the certificate of need process. And I pulled them together sort of collectively for your purposes of your discussion. And I'll just go through them quickly, but each of them proposes to repeal a particular requirement in the statute for when a certificate of need is required by a hospital or a healthcare facility or nursing home in certain circumstances. So LD 927 would repeal the requirement for a certificate of need for the offering of a new healthcare service by a healthcare facility. And the statute defines a healthcare facility to include hospitals and other facilities like ambulatory care centers. And we can talk further about how the statute defines both a healthcare service and a healthcare facility as you move forward if you have questions. The second bill, LD 931, repeals the requirement for CON for adding new licensed beds or increasing beds in a facility other than a hospital. LD 932 would repeal the requirement for CON prior to any increase in licensed beds by a hospital. LD 935 repeals the requirement for a CON for establishing a new healthcare facility. And lastly, LD 1004 repeals the CON requirement for the acquisition of major medical equipment. And again, the statute defines the term major medical equipment and establishes some monetary thresholds for the expenditure that the acquisition has to meet in order to trigger that certificate of need process and approval process. You had a lot of testimony that was submitted on these bills collectively. Hopefully you've had a chance to review some of that. You also received some articles and studies related to the CON process. I attached some links here to the current law. As I think you're all aware from the hearing, the CON process in Maine is overseen by the Department of Health and Human Services, their Division of Licensing and Certification. I provided some links both to their website, and then they do provide information on both the current reviews for CON that are in process and also provides information about past CON reviews. The statute also requires annual reporting on the CON process to the legislature. I also provided some links to additional information from the National Conference of State Legislatures. They have an extensive web page about the CON process, and they provide lots of information and resources there, both about other states and how they deal with the CON process. But I have to say there's really no uniform way that states address CON. The state laws and requirements in each state really vary widely as to what types of activities in healthcare, in the healthcare delivery systems in their states require a CON process or not. And then the NCSL website also has a number of links to federal resources from the Federal Trade Commission and the United States Department of Health and Human Services. There's been some recent work there related to CON process from a competitive standpoint. I'm happy to stop sharing now. I know Senator Sanborn mentioned it, but you do have folks from DHHS here with you in the attendee list. I know Mr. Montejo, who testified at the public hearing, was hoping to be available, but I think you have staff from the Division of Licensing and Certification who are here in the attendee room who could provide some answers to your questions if you have further questions about the process.
Okay. So I, as Colleen said, I'm not entirely sure who's here from the department. If that person could just raise their hand.
Yeah, I think there's two. I just don't know who
Okay.
wants to speak.
Well, we can bring both of them in, and then we can use them both as a resource.
I'll promote them both.
Okay, thank you.
Christian, get the.
Yep.
Here they come.
Great. Welcome, Mr. Carbonneau, and I don't know how to pronounce. Is it Hadinac?
Hadiniak.
Hadiniak. Okay, I didn't have quite enough syllables there. All right, so thank you both for being with us this afternoon. I will kick it off to get the conversation started. We heard some testimony during the CON hearings that sort of the first thing that happened during the pandemic was, or one of the first things was, that CON was suspended. So can you help us understand in context, why was CON suspended and why shouldn't we make that permanent, having been through that experience?
Yes, Senator Sanborn.
Go ahead.
Yeah, well, CON was not suspended. Part of the CON law provides for an emergency action on a certificate of need. And that was exactly what we ran into, is for the potential for hospitals to need to add beds. They asked for an emergency CON and we processed 11 of them. So 11 of the 16 hospitals that normally could add beds asked for permission to, if they needed to, have more beds. And that's over and above the ability to have added 10% on their own, as you know, from the statute already. So in this case, the emergency clause of the CON worked perfectly fine. I think the only thing that was sort of allowed through was the blanket approval of this sort of certificate of need emergency action. So we didn't have to send it to the commissioner, who obviously was very busy last March and April. So we were meeting a need of the hospitals in case they needed to expand the number of licensed beds they had.
Okay. Are there additional questions for our representatives from the department? All right, I don't see any. So I will thank you for joining us, and we'll send you back through the wormhole. And I'll open it up to the committee for further discussion on these bills. Representative Morris.
Yes, thank you, Madam Chair. I will be supporting all 5 bills. I think this has become, I think we've seen other states that have done this. I think it works better that way. I think I certainly have a lot of respect for the Hospital Association and for Mr. Austin. But I would say that, and I certainly appreciate what he said about giving them a free market. Nobody appreciates that more than me. But I would say that this is about, for me, what we can do for consumers being able to find healthcare services closer to home, also finding efficiencies within the system, rather than having to go every time to government to get something for new facilities, hospital beds, all the things that are listed in the by the sponsor on this topic. I think the issue is they're still going to have to do their due diligence to figure out if what they're doing wherever they might want to put a new facility or a new service, they're going to have to do their due diligence just like any business does when they want to open up a new service. But I think by doing this, number one, I think it benefits consumers because they're able to find something that may work better for them instead of having to wait for government to act. I think it's really problematic that you have a situation where you have to wait for that government is coming in and determining whether or not there is a need in a community or something like that. I think that that's something that can be determined by whoever, by the market and people doing research in the market as to where there may be a healthcare need. I would rather leave that up to the market and to people being able to determine what they need for their healthcare, rather than government deciding that there is sufficient services in an area. I certainly respect the department's points that they made, but I think the fact that you have an emergency asking for more hospital beds potentially, and thank goodness we did not need them, but I think that sort of underlines and underscores the need for these bills. Thank you.
Thank you, Representative Morris. Are there other comments or question or discussions from the committee? I will, seeing no hands go up, I will lay out why I will not be supporting these bills, which is that we don't have a free market with regard to healthcare. And to the extent and in the places where we do have one, it tends to have a lot of issues and have a lot of problems, which is why we have a lot of bills in this particular committee to continue to regulate different aspects of the market. And so my concern, and I think what we would see if the CON process were repealed and if things were allowed to really just sort of go where the market goes, is that rural areas would not see large influx of, infusion centers or dialysis centers or ambulatory surgical centers or other types of for-profit organizations, because there's just not the demand for those things in those locations. If there were, then a CON would be likely available and approved, because we certainly know that we want to provide services in rural areas, but that's generally a lack of beds isn't generally the issue. The issue is a lack of providers and a lack of demand with any kind of strong rate of return attached, because the payer mix in those rural areas tends to be very heavily Medicare and Medicaid as well, which we know is very difficult to make profitable. So I think what we would see instead is an erosion or more building of medical facilities in my area of the state, perhaps additional competition in my area of the state. But I don't necessarily think that on balance, that is always a positive, particularly because if you build it, you've got to then provide additional services and charge for those services. So I don't think that on balance, that is, it necessarily impacts us by having price competition, and instead it may tend to inflate services and utilization because it needs to justify its own existence. And so having said all of that, because I don't think that removing CON moves us in a direction of saving costs, of providing greater access in rural areas, or of just improving our overall healthcare system, I will be voting against the CON bills. I guess I would also note that not all that long ago, we did amend the CON. It was before my time, and this committee actually has never addressed CON specifically because it just fell under our jurisdiction starting in the last session. But it was amended so that things like urgent care facilities and other small facilities can be exempted from the CON provisions. And, I think we've seen the results of that already. And I think we'll continue to see some of the results of that. And those results, unfortunately, may be loss of emergency rooms in some of our rural areas at times, and that's worrisome to us as well. So, with those comments, and I'll just open it up for other members of the committee want to make a comment. Representative Quint, go ahead.
I kind of understand where you're coming from, Senator Sanborn, with that. However, once again, if there are more facilities in your area, there will be less of a wait time from the people in my area that are coming to those areas. We still are timed out in a lot of our procedures, in which it takes much longer for us to get in. This has happened with myself. It's happened. And I still see having better competition would help rural areas, even if that competition took place in your areas as well. The wait times, they're very long. So I know a lot of people in the busier areas may not see that as much. But having to wait for procedures or having to wait for diagnostics is a problem for our area. So I just wanted to put that out there.
Thanks, Representative Quint. Senator Brenner, go ahead.
Thank you, Madam Chair. I just want to once again reiterate the point that folks could get a CON in any of these rural areas that they'd like to. They're just not seeking to do it because there's not any profit to be made. And so removing the CON is not going to solve the problem that we're all looking to solve collectively as a committee in terms of increasing access and affordability in rural areas. The thing that's going to do that are going to be federally funded health clinics, state funded health clinics, but it's not going to be removing the CON, because already we have the ability for healthcare companies to open services up there. They're just not choosing to do it. And I don't think the CON is what's the burden in the way. I think it's the profit that can't be made. So I'll be voting ought not to pass on these bills.
Representative Arford, go ahead.
Thank you, Madam Chair. And I will also not be supporting these bills at this point in time. I agree with what has been said. I also understand what Representative Quint is saying. There is a need, and we need to figure out how to address that need. So the challenge to us is to develop and pass laws that actually will address the need for additional services in the rural parts of our state. And I'm with Representative Quint on that, and I'm happy that we are working together as a committee on that. And the final thing I'll say is, these bills have been here before. My sense is they'll circle back again in the future. And if things change, I will continue to research this issue. I've heard from constituents who asked me to support these bills. And I want to respond to them and say, I would like to talk to you further about this. I will continue to research it. And if things change in the future, I might possibly support them. But not
Representative, thank you, Representative Arford. Representative Evans.
Thank you, Madam Chair. And I just wanted to comment. I understand what Representative Morris is speaking about, and I certainly understand your position, Representative Quint. Being in rural areas is totally different. I don't believe that this is the route that we want to take to try to rectify numerous other problems. I don't see the certificate of need as being the end all to the problems in our overall healthcare system. We're not going to get a new ambulatory care center in my area in Dover Foxtrot. It's just not going to happen. So although I understand where you're coming from, I think the approach that these bills are taking is not the solution. Thank you, Madam Chair.
Representative Morris, go ahead.
You have to unmute. Thank you, Madam Chair. I appreciate, where you folks are coming from and your concern. And I would say that this is not, the argument we're making is not that this is the end all, that this is going to solve all of the issues with it, but it's one piece of that puzzle of what needs to be done in regards to healthcare. And it's not just about, it isn't just about getting more stuff into rural Maine. I certainly understand the points you're making on that particular issue. It's also about allowing for more innovation within the delivery of healthcare services. And, you know, to your point about with lifting the certificate of need for more urgent care, I think that's sort of an example of how that has helped, because you are seeing more. And I think obviously the goal, as we've looked at other bills this session, is to relax, to help provide some relief of the burden on hospitals. And like Representative Quint said, the wait times and some of the other issues that people experience. And I'm not saying that certificate of need is the sole reason for that by any stretch of the imagination, but I think this is one tool we can use to start moving in a different direction, because we have to, we've done a lot in my time on this committee to try and add more mandates onto the health insurers about what needs to be covered. But we need to do more to address things like cost, and competition is one way to address costs, is by having more competition within the marketplace to allow for more innovation. So that was really the overall point that I was trying to make with my initial, when I kicked off this discussion. But I certainly understand where you guys are coming from. However, I still think that these are good bills, and I think again, it's about starting to move us in the right direction on some of these issues.
Yeah, I think unfortunately, Representative Morris, that some of us fear this actually starts to move us in the wrong direction. And I think with regard to the comment you made about relieving some of the burden on hospitals, I think that the concern is that what it may actually result in doing is taking away any part of the hospital book of business or panoply of services that they offer at which they can make a profit, skimming those off the top and moving them to a private for-profit center outside the hospital. And then the things that have to be in a hospital setting, like a 24-hour trauma care ER, which you can't make money at, starts to become the only thing that our hospitals, are exclusively doing. And then we have a real issue with access and with ensuring that places, I think we saw it in Booth Bay, places that are a bit more remote, but that still have a hospital or an ER, start to lose that ER or lose that access to emergency care. So Senator Brenner, go ahead. You're on mute.
I would just like to make the point that we have been trying free market in healthcare for quite a long time. We had plenty of small hospitals at one point in Maine that are now owned by a handful of larger companies because it didn't work out for them. They consolidated out of need. So what we've been trying hasn't been working with free market, and the CON was put into place a number of years ago to try to create some boundaries, some gates around that experience. So I'm just not ready for us to let it go. I don't think it's time.
Representative Morris, go ahead.
Thank you, Madam
I
Chair.
almost called you by your first name. I apologize.
That's all right, no worries. And I don't mean to keep belaboring, but I would say, in terms of, to your point, what you just said about with the hospitals, and if the people choose to go to these other systems, for something, then I would argue that, number one, they're finding the service to be better, or they're finding that the cost is probably better, that this is what the consumer would be finding, and that I think in turn, The hospitals would have to then figure out a way to, rather than just having people go there, they would have to, improve their services and improve the way they deliver their services as well. So I think it's a win all around. I think the hospitals can then themselves figure out a way to innovate, because right now there is no incentive within the health care system if they know that that someone has to come in and show the certificate of need and say, you're not going to significantly impact their business, their book of business. I think that is what I find most troubling about certificate of need.
Representative Matheson.
Thank you, Madam Chair. I think I understand your argument, Representative Morris. I'm an integrated practitioner. I like free access. I want expanded access for people. I like people to have affordable health care, but I don't think that we're talking about oranges to oranges, because there are other parameters that hospitals they're mandated to do: charity care, Medicare, all of those, which some of the free market options wouldn't be mandated. So you don't have a level playing field there. And if you're skimming off the only areas where the hospitals actually can profit with different services, I don't see that as being a free market or a level playing field at all.
Are there additional comments? All right, it's been a good discussion. I don't think we changed anyone's mind, but I think it was a good substantive policy discussion, which is what we're here for. So I appreciate that. I'm going to make a motion. Let's see, I need to find the bill numbers here. I apologize. Let me get back to the right screen. So I am going to make a motion on the first one, which is LD 927, ought not to pass. Is there a second? Seconded by Senator Brenner. And is there any further discussion on LD 927? Seeing none, the clerk will call the roll.
Representative Quint.
No.
Representative Quint, no. Representative Connor. Representative Connor is absent. Representative Blyer.
No.
Representative Blyer, no. Representative Morris.
No.
Representative Morris, no. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler. Representative Tepler is absent. Senator Sanborn.
Yes.
Senator Sanborn, yes. That is 1, 2, 3, 4, 5, 6, 7 yes, 3 no's, 3 absent.
Great, thank you. So next I'll make a motion on LD 931 ought not to pass. Is there a second? Oh, Colleen, go ahead.
Sorry, I don't mean to interrupt. Is the minority report just straight ought to pass, or would you like to amend it in some way?
No, ought to pass.
Okay, great, thank you.
On LD 931, I would move ought not to pass. Is there a second? Seconded by Representative Evans. And the clerk will call the roll.
Representative Quint.
No.
Representative Quint, no. Representative Connor. Representative Connor, absent. Representative Blyer.
No.
Representative Blyer, no. Representative Morris.
No.
Representative Morris, no. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler. Representative Tepler is absent. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 7 yes, 3 no, 3 absent.
All right, with regard the minority report would be ought to pass?
Yes, ought to pass.
Yes. And with regard to LD 932, I would move ought not to pass. Is there a second? Seconded by Representative Brooks. And the clerk will call the roll.
Representative Quint.
No.
Representative Quint, no. Representative Connor. Representative Connor, absent. Representative Blyer.
No.
Representative Blyer, no. Representative Morris.
No.
Representative Morris, no. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler is, give her a second. Senator Sanborn.
Yes.
Senator Sanborn, yes.
We can let Representative Tepler vote on that a little bit later.
Sounds good. That's
She's just joined. Okay.
7 yes, 3 no, 3 absent. Is it ought to pass minority report again?
Yes.
Okay. So now with regard to LD 935, I would move ought not to pass. Is there a second? Representative Matheson has seconded. We're going to get through all of the seconds here, just to make Christian's life more difficult. All right, seeing no further discussion, the clerk will call the roll.
It's the longest last name too. Representative Quint.
No.
Representative Quint, no. Representative Connor. Representative Connor is absent. Representative Blyer.
No.
Representative Blyer, no. Representative Morris.
No.
Representative Morris, no. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes.
And I want to make clear to anyone listening that I participated in the caucus and in the public hearing, even though I haven't been here for the discussion. Thank you.
Senator Sanborn.
Yes.
Senator Sanborn, yes. That is 8 yes, 3 no, 2 absent. Is the minority ought to pass again?
Yes.
Nice.
Great. And the last of these is LD 1004, and I would move ought not to pass. Is there a second? So, Representative Evans seconds. It's a shorter name for you.
Heck yeah, it is.
All right. The clerk will call the roll.
Representative Quint.
Long week.
Representative Quint, no. Representative Connor. Representative Connor is absent. Representative Blyer.
No.
Representative Blyer, no. Representative Morris.
No.
Representative Morris, no. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans. Representative Evans, could you unmute your mic?
Sorry, yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 8 yes, 3 no, 2 absent. Is the minority report ought to pass?
Yes.
Okay. There's a hand up. Whose hand is up? Oh, Colleen, it's right over your
I know, I've got to change it.
insignia, so I can't see it.
I got to do that differently. I just wanted to say that there may be, because we're repealing some statutory requirements related to a regulatory process, there may be some fiscal notes needed to be attached to the ought to pass votes. So with your permission, if that happens, we'll just change it to ought to pass as amended for purposes of the fiscal note, if that's okay
Yep.
with those who voted ought to pass. Okay, great. Thank you.
Yep.
And Christian just suggested, and I think it's a good idea, Representative Tepler, if you are amenable to it. Obviously, there were a series of those bills, and you missed some of the votes, and Christian wanted to catch you up now so that we could save the email chain. So I'll have Christian ask you for your votes on those.
On LD 927, the motion was ought not to pass. Representative Tepler.
You're muted.
One second. I think it's yes. I need to know.
Yeah.
Can you give me the title of the bill?
These are all the certificate of need bills.
Okay, then my answer is yes.
Representative Tepler is yes on 927. Then on LD 931, the motion was ought not to pass. Representative Tepler.
Yes.
Representative Tepler is yes. And then on LD 932, the motion was ought not to pass. Representative Tepler.
Yes.
Representative Tepler is yes. Okay.
Great. Next, we'll do a work session on LD 1119. And we're veering off in a slightly different direction here for just a moment. It's an act to limit credit card fees by requiring monthly credit card billing. Colleen, why don't you?
Do you want me to? Okay.
I guess so.
Sure.
I guess so. I'm not sure how else to jump into this other than to have you
Oh.
present it.
Yeah, let me see. There we go. Okay, I think you guys can see it now. LD 1119, as Senator Sanborn said, would require deals with monthly credit card billing. It would require issuers of credit cards to bill once per month a holder of a credit card who has a balance due on that card. It would provide that the issuer may not bill more than once per month. And if the issuer of a credit card bills a holder more than 12 times in a calendar year, the language would require that issuer to forfeit the balance on that holder's credit card and prohibit them from reporting any negative information to a credit bureau or credit reporting agency. Maine's Truth in Lending Act, which has provisions in it that deals with issuers of credit cards, incorporates the requirements of federal law incorporates them by reference in our statute. And under federal law and regulations, there are provisions that address this. Payment due dates for credit cards must fall on the same day each month. Credit card holders must receive a monthly bill at least 21 days before it is due, so they have time to make the payment. And then federal law also does include exceptions for certain situations when a monthly statement would not be required to be sent. For instance, if there's there's no balance on the card. And as we've talked about before, when it comes to issues related to the regulation of financial institutions as drafted, the bill would apply only to financial institutions organized under a state charter. And financial institutions may be organized under either a state or federal charter. And the application of the bill's requirements to federally chartered financial institutions would likely be preempted, as was noted in your testimony, from a number of entities, including the Bureau of Financial Institutions. Federal law preempts state laws expressly, and that includes in the federal regulations, includes those relating to the terms of credit, including the schedule for repayment of principal and interest. So if the bill does move forward, it would likely not apply to all banks and credit unions operating in Maine. I don't think I'll really say anything more. We don't yet have any fiscal information on this bill, but there were a number of other factors related to the language of the bill as drafted that were raised in testimony.
Thank you, Colleen. So is there comment on this bill or questions for Colleen? Representative Matheson.
I guess I'm just confused about the bill. It seems like we already have this in law, so I don't really understand the purpose of this bill. Am I misunderstanding that?
There certainly are requirements related, as I mentioned, in the federal law and the regulations about requiring that a bill be sent when there's a balance. But I think the testimony that the sponsor of the bill who I think may have been the only proponent who testified on it, raised the issue about certain practices that were brought to his attention where bills may be sent more than once per month. And while the consumer would not be responsible for interest, for instance, could not be accrued on that account more, except on a monthly basis, and that's set forth in the statute or according to the billing cycle. There was some concern that he raised, I think, in the testimony about the potential for fees or late fees to be collected if there were additional statements provided more than once per month. So I think that was part of the concern that was raised. But as I mentioned, I think it's clear the federal law requirements are set forth, and there would be, if it did move forward, it has the potential of setting up different treatments between the state chartered and federally chartered institutions in the state.
Right. Additional comments? Okay, seeing none. I see that the sponsor is with us, and I haven't had a chance to speak to him. I would like to bring him into the meeting, just to ask, like, if there's a specific practice here that he's really seen in action, because I think that's the piece that we're all missing a little bit. Oh, I just saw him.
I thought he was coming
here.
Let's see. I thought I saw him coming. Maybe it's the same issue we had this morning.
Maybe.
Maybe you want to try to promote him? I'm trying, but it doesn't seem to be working.
Sure.
I don't know if Christian can do it. He disappears on my attendee.
Yeah.
And then he shows back up.
And then he shows back up.
I don't know what's happening.
Well, Senator Mearmont, we're trying to help bring you into the meeting. I might be able to allow him to talk.
Yeah, that's what I was just thinking.
Yeah.
Whoop, I promoted someone else by accident.
But we were able to promote that person. I'm not sure why we can't promote Dave.
There he comes.
There he is. All
That's so weird.
Oh, nope. He disappeared. Christian's like falling off his chair. Okay. All right. Let's just one of us work on it at once. Who's doing it? Christian's doing it. Okay. Here it comes. Maybe. Maybe not. Do. All right. I don't see it. All right. Now he's just lost in space. All right. Let's because now he's not attached to the meeting at all, so I'm not sure exactly what to do.
That happens in wormholes sometimes.
I know the wormhole has closed. All right, I'm gonna click allow to talk.
I see him now.
Talking permitted. Senator Mearmont, can you hear us? We can't hear you. Does say talking permitted. Are you talking? Okay. All right. Seems not to be working very well. It's possible he has a very unstable internet connection. That might be why the wormhole isn't working. That's my guess. So I am going to withdraw the question. And I hesitate to table the bill because we really need to move through this. And there are some issues with regard to federal preemption that I think are dispositive anyway here, because this would only impact Maine banks and credit unions and would potentially be federally preempted otherwise. So I guess although I'm a little bit puzzled still as to what the problem was the bill was trying to solve, I'm also not feeling like this is a bill that I could vote in favor of in its current form, because of the federal preemption issues and because of the state federal banking law issues. So with that said, is there further discussion? Is there a motion? Representative Quint, go ahead.
I will make a motion for LD 1119 on not to pass.
Okay, and is there a second? Representative Matheson seconded. And I'm just gonna give one more attempt here to Senator Mearmont. Senator Mearmont, can you hear us? We cannot hear you. We are trying very hard to hear you, but we can't. All right. So the motion is on not to pass because of the federal preemption concerns and because it would only apply to Maine banks and credit unions, which we don't think are doing this type of practice anyway. So that's sort of the motion. The second, is there any further discussion? All right, the clerk will call the roll.
Representative Quint.
Yeah.
Representative Quint, yes. Representative Connor. Representative Connor is absent. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Melorano.
Yes.
Representative Melorano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That is 11 yes, 2 absent.
Okay. And so next, let's pick up LD 1115, and I guess I'll ask Representative Tepler to drive the truck because it's my bill.
All right, I'm happy to drive the truck, but that means we're turning to Colleen and asking her to please give us her bill analysis on 1115.
Or LD 1115, as it's drafted, would meet the standards for a mandated health benefit proposal, although the legislation as drafted would exempt the bill from having to undergo a review and evaluation by the Bureau of Insurance. So I have included it on the sort of the chart that we've been maintaining this session that for the group of bills that meet that statutory standard for further review and evaluation. So LD 1115.
Colleen, I think it's too small to read.
Yeah,
I don't know if you could.
Yeah, I'm gonna go up. How's that?
There we go.
Just about to do that. So LD 1115 as it's drafted, while it does have a provision that relates to requirements for health insurance coverage for HIV medications, it also has two other components. The first component is language that would require any drug formulary used in the main care program to ensure that HIV prevention drugs are available to members covered by main care. The second component that I just alluded to is a requirement that health insurance carriers provide coverage for an enrollee for HIV prevention drugs that have been determined to be medically necessary by a healthcare provider. The language as drafted does provide the circumstances for which that coverage must be provided by a carrier. It also would prohibit carriers from imposing prior authorization or step therapy requirements for those drugs, subject to certain conditions. As it's drafted, further, the health insurance provisions would apply to health insurance plans issued or renewed on or after January 1 of 2022. And then the last component of LD 1115 is language that would authorize pharmacists to dispense and administer HIV prevention drugs under certain conditions without a prescription, in those circumstances, subject to rules that would be adopted by the Maine Board of Pharmacy. I can sort of highlight for you some of the things that were brought up at the public hearing, but I also can share, if the committee would like to see it again, Senator Sanborn distributed a proposed amendment to LD 1115 that sought to clarify some of the issues that I'm going to briefly talk about. But you did have testimony. A couple of things I wanted to point out about some written testimony that you got that you did not receive at during the public hearing. One, with regard to the main care provision, you did have testimony from the Department of Health and Human Services indicating that they do currently provide coverage through their formulary for 2 PrEP medications without prior authorization for members. So the provision in the language in the bill would really just codify what is happening in practice. And then the second thing, which I think you heard at quite a bit about at the public hearing, is federal requirements, which are now codified in Maine law as a result of legislation enacted last session, considers PrEP as an A-rated preventive service pursuant to the ACA. So health plans would be required to provide coverage for these medications with no cost sharing. Although I did want to point out that the federal guidelines do permit health plans to cover selected generic or brand name drugs and require prior authorization. So it doesn't require coverage of PrEP as a preventive service for all types of drugs. It does allow what they call reasonable medical management kind of procedures on the part, reasonable procedures on the part of carriers.
Pauline, can you address whether or not Heather has taken care of these provisions in her?
Yes.
Sort of as we go along would probably help save time.
Yes. And so an amendment was suggested to align those federal requirements with and require coverage with no cost sharing. And that is addressed in Senator Sanborn's proposed amendment. And instead of the approach that the language of the bill as drafted took in terms of requiring, if there are therapeutically equivalent drugs, a carrier would be required to cover at least one therapeutically equivalent drug at the tier with the lowest cost sharing. The amendment that Senator Sanborn proposed would look at the methods of administration of these HIV prevention drugs and would require coverage of at least one method of administration with no cost sharing. So I can highlight that as we go forward. And then another amendment that was suggested about the health coverage provisions was specifying that coverage required for associated lab testing for those taking PrEP would be addressed in the as you move forward. And the amendment that Senator Sanborn has proposed would include language requiring carriers to cover that associated lab testing. As I mentioned, the language of the legislation included an exemption from the Bureau's mandate review. You did have some further amendments that were suggested in testimony from those others that testified or submitted written testimony. I think it was representatives of pharmacy benefit managers suggested that the language in the legislation that exempted these medications from prior authorization and step therapy protocols be removed from the legislation and use really some of the those existing provisions rather than require coverage without prior authorization or step therapy. And then with regard to the pharmacist provisions, Maine Medical Association suggested an amendment reducing the amount or the maximum supply of PrEP that a pharmacist could provide without a prescription from 60 days to 30 days. The language of the bill and the amendment actually that Senator Sanborn put forward maintains that maximum 60-day supply. And then representatives of the Osteopathic Association suggested requiring a pharmacist to have a specific collaborative agreement with the pharmacist in place. Although I would mention that the language of the legislation does require the Board of Pharmacy to adopt rules about how the authority for a pharmacist to dispense this medication. Does it make sense to share the amendment and sort of highlight that now, or I'm happy to go through, answer any questions that you might have.
I think maybe it makes sense for you to share the amendment because I think that's what we probably want to be voting on and not necessarily the original bill. So let's focus on that, and then we'll ask questions around that.
Sure. And I can just highlight, this was, I was able to distribute this to everyone this morning. And the changes are shown in bold italics. Hopefully it will show up on the Zoom screen fairly well. But there were no proposed changes to the language in the original bill that I mentioned relate to coverage under the Maine Care Program. So sections 1, 2, and 3 remain unchanged. With regard to section 4, which is the section that imposes requirements with regard to health insurance coverage, I'll just highlight for you the change that I just described in terms of which drugs a health insurance carrier would be required to provide coverage for. And in paragraph A of the proposed amendment here, you'll see those changes that reflect focusing more on the method of administration of the medication, as opposed to whether or not there's a therapeutic equivalent. So paragraph A would now require that.
Holly, can you screen share that? Is that possible?
Oh, I thought I did. I'm sorry.
No.
I apologize.
All right. I thought you thought you did. That's what
I know. I'm looking at my screen and it's showing up here. I didn't know you guys didn't see it. So I'm sorry.
Right.
So here's the first change really that I wanted to highlight. Can you see this paragraph A that I'm talking about?
Yes.
So paragraph A would now require that if the FDA has approved one or more HIV prevention drugs that use the same method of administration, a carrier would not be required to cover all of those approved drugs as long as they covered at least one drug for each method of administration with no out-of-pocket cost. Paragraph B just makes a technical change that carriers would not be required to cover these medications dispensed or administered by an out-of-network pharmacy unless they provide an out-of-network pharmacy benefit. And then an additional technical change related to the language in paragraph C. In subsection 3, which is the language that relates to prior authorization and step therapy requirements, again, following through on that, the focus on the methods of administering these types of drugs, the language would be amended to say that if the FDA has approved one or more methods of administering HIV prevention drugs, a carrier would not be required to cover all of those approved drugs without prior authorization or step therapy, as long as they covered at least one approved drug for each method of administration without prior authorization or step therapy requirements. And then it further goes on to say that if enrollee has met prior authorization or step therapy requirements with regard to a particular drug, the carrier would then be required to cover that drug with no out-of-pocket cost to the enrollee. So in the event that an enrollee was subjected to prior authorization or step therapy, the carrier would then be required to cover that drug with no out-of-pocket cost. And subsection 4 is new language that addresses the issue of laboratory testing that I mentioned. And it would require carriers to provide coverage with no out-of-pocket cost for the lab testing that would be recommended by a provider related to the ongoing monitoring of an enrollee who is taking an HIV prevention drug. So it's the scope of the testing that would be required. It would be that testing that's recommended as part of their ongoing monitoring. And then subsection 5 and 6 of the bill relate to making changes to the authority for pharmacists to dispense and administer HIV prevention drugs. And really the change here is just adding reference to both dispensing and administering HIV drugs. There are really no substantive changes in Senator Sanborn's amendment to these provisions. Although I will note that the Board of Pharmacy in their written testimony to the committee on the original bill and in providing some comments to Senator Sanborn's proposed amendment has suggested some additional technical changes if the committee moves forward with the legislation relating to just really making clear in the statute that if the intent of the legislation is to allow or authorize pharmacists to provide these drugs without a prescription, that there should be some language sort of authorizing the pharmacist to both prescribe, dispense, and administer those drugs in that situation. So if the committee does move forward, we'll make some technical changes and really just trying to align the statute with some current law provisions related to the pharmacist's authority to prescribe and administer naloxone, for instance. So they just suggested some clarity and consistency in the language there if the committee moves forward. Then lastly, I'll just point out section 7, which was in the original bill, provides an exemption from the mandate review, and section 8 is the application provision.
Okay, I see Senator Sanborn wants to say something. Go ahead. I think that's all right as a member of the committee and the sponsor.
Thanks, Representative Tepler. I just wanted to make a couple of comments about the amendment and why it does certain things and doesn't do other things. So first, I wanted to address the mandate review question. And I think the reason it makes sense to exempt this from mandate review is because it's already mandated under the ACA because of the U.S. Preventative Task Force making its recommendation last year with regard to PrEP medicine. That automatically triggered mandated coverage. So what we're doing is really just kind of putting some extra guardrails and clarity around that already mandated coverage. So in that sense, I don't think that mandate review would be fruitful or appropriate. I think it would actually be a waste of money on this particular bill because it's already mandated. And then I wanted to address the 30-day suggestion that the MMA had thrown out there. So the idea of the second piece of the bill really is to provide quick and low barrier access to PrEP and then to channel those folks immediately into a primary care setting. But the issue is that it would be very difficult to get a primary care appointment within 30 days. So if we only give people a 30-day prescription, they aren't going to be able to actually make and complete their primary care visit within that 30 days. And then we're more likely to actually just lose them entirely and they'll go off of PrEP again potentially. And then the public health purpose of the bill hasn't been served. So that was my motivation for sticking with the 60 days, is that I think the reality of our primary care access issues, which we heard for 2.5 hours plus about this morning, is that getting an appointment within 30 days would be a very high barrier to continuing your PrEP prescription. So I think 60 days is very reasonable, and the requirement to hand off to a primary care physician is already very much baked into the bill, and I think is a best practice in that regard. So I just wanted to sort of preemptively explain those two pieces of the bill. I'm also obviously happy to answer questions about any of the other pieces of the bill that you might have questions about as well.
Are there questions from the committee? I see that Representative Morris has one.
Yes, thank you, Madam Chair. I just had a question actually along those lines on the 30, 60 day supply issue. I just wondered, and I'll leave it up to you. I don't have a problem with leaving it as is, but I didn't know if we wanted to take out the 30-day entirely and just have it up to 60 days in case there was a scenario where someone wanted less than 30 days, but I will leave that up. Let you answer that question. Leave it up to you. That was just one question I had.
I mean, if someone wanted less than 60 days, Representative.
Wanted less than
No.
30 days.
Yeah, so can I address that, Representative Tepler?
Yes, please.
So the language, I see the language you're looking at, Representative Morris, and it says the pharmacist shall dispense or administer PrEP in at least a 30-day supply and up to a 60-day supply. And I guess I would say I think that makes sense. And I'm not sure that a smaller increment of dispensing makes much sense, particularly when you start to intersect it with insurance coverage, which generally, you know, has a sort of a 30-day dispense kind of standard as well. So I feel like that makes sense. We're also talking about zero copay medicine. So the reason for not dispensing, you know, 30 days is often because you can't afford it or something like that. But this wouldn't be the case in this particular regard. So I feel like we're on solid footing there, but I'm certainly, yeah, I appreciate the question. Representative Arford?
I just want to make sure I understand properly the mechanism of the pharmacist prescribing this drug. So someone in need would go to the pharmacist. It was my understanding the pharmacist can now dispense and deliver pharmaceuticals. I didn't realize they had the authority to prescribe a pharmaceutical. So just a little bit of explanation, will that be worked out in the rules? I'm not really sure about that. And then the other thing is, what type of guardrails are there on, say, someone who comes to gets the 60 days, you know, there goes home, 60 days go by, they still haven't gone to follow through with a primary care provider for whatever reason, and then they go back to the pharmacist. What happens then?
May I address the questions, Representative Tepler?
Yes, you called on her. So go ahead.
Oh, I'm sorry. I apologize.
No worries. It's a shared responsibility.
I apologize, everybody. I'm really bad at remembering who has the gavel. Okay. So I'm embarrassed now. I'm blushing.
Sorry, I just was teasing you.
So on page 4 of the bill, Representative Arford, in section B6, the pharmacist is not allowed to dispense or administer more than a 60-day supply to a single patient once every 2 years, unless otherwise directed by a practitioner. So there's some guardrails there with regard to that, and there's also notification of one's primary care doctor that is required as part of the statute. And so I assume the next question might be, what if they go to a different pharmacist? But because there is that requirement to notify the primary care doctor as well, that is, you know, a way in which this could be tracked if someone were doing that, you know, going to multiple pharmacists. But I think the other really important thing to note is this is a medicine that we really want people to get. And that is what this bill is all about. This isn't like someone going to multiple pharmacies to get narcotics, where it's not a drug we want them to get necessarily. But instead, you know, PrEP, you don't take like twice as much or something. Like that's not, you know, it's not a drug that is abused. It's a drug we really want people to have continuous access to, and this is a way of breaking down those barriers. So I hope that addresses your concern.
But that was part, but my bigger question was, if they don't yet have a primary care doctor and they go back, maybe they just didn't, I mean, none of us are perfect, and they're told by this pharmacist that they cannot get another prescription. Is there any fail safe for them to be, because they need to continue on the drug continuously, correct?
Oh, yes,
That's
sorry, I thought you were asking the opposite
I
question.
mean, is
I
there
think
any
that
safe where they could, an emergency second dose or anything like that?
no, I think the purpose of this is to ensure that pharmacists don't sort of supplant primary care doctors as the provider of choice, but instead to provide that initial on-ramp to care. And so the handoff to the pharmacist, from the pharmacist to the PCP, is very much baked into the bill, because that would be the correct, way of trying to channel care. It won't work in every situation, but it's certainly much better than what we have today.
Thank you.
Mm-hmm.
Oh, what about the question about for the prescribing? That was my other big question. Their ability to actually prescribe the drug that's a brand new authority, correct?
Go ahead, Heather.
Yeah, so with regard to naloxone, we have allowed for that. I think actually with regard to COVID vaccines, we have sort of allowed for that at this point as well. It would be subject to all of the rules and training requirements that the pharmacy board would have to promulgate. And so there would be standards for authorizing pharmacists to prescribe, dispense, and administer the drugs, and that adequate training requirements and protocols for doing so would have to be developed by the pharmacy board. And I think, again, because we're in an area of public health and of a non-abused medication, but one that is really unlike any other medicine, that it's much more like a vaccine, right? But it's when you have to take every day. So but it keeps you from getting sick. So yeah, so that's what I would say. It's more analogous to a vaccine.
Thank you.
Mm-hmm.
Thanks. Representative Evans, go ahead.
Thank you, Madam Chair. I think Senator Sanborn answered the question. This is one of those situations where this is a drug that you really want people to have. And so the Board of Pharmacy will automatically take that into consideration to make sure that they maintain currency with the primary care physician, because somebody had to make the prescription in the first place. And even if they can't get back to that individual, at least that office can direct them to the proper next person to get the prescription refilled.
Are there additional?
Thank you, Representative Evans. Yeah.
You put me on myself on.
If you want to take back over, it's okay, but it's your bill, so you asked me to. So are there any other questions or comments from the committee regarding LD 1115? Yes, Representative Morris.
Yes, thank you again, Madam Chair. So as we discuss this bill, we certainly agree with Section 5 of the bill. We think people need to have access to these drugs. I think it's certainly very important. I think that was the intent behind the federal government trying to offer these drugs. Is we do want to eliminate HIV. As I understand it, Section 1, 2, and 3 we're fine with. I think as I understand it, though, this is already being required by federal law as far as the mandates on the coverage of it being supplied without copays, with nothing out of pocket for the prevention of HIV. But I also, from the hearing and from talking with others, it is also covered. These drugs are also used as treatment for HIV, and that is not currently covered under federal law with a copay. And so we would want state law to align on that issue, where there is certainly, because as I understand it, it's looking at it in through two different trajectories. So our thoughts are, where this is already being done under the federal law, is we would like to see Section 4 eliminated from the bill.
Comments? This sounds like something maybe the sponsor wants to comment on.
Sure. So I think that actually what we have provided here gives some clarity to what is going to be required. There was some discussion actually from the advocates who said all the drugs have to be covered, or and what this does is say, no, not all the drugs have to be covered, but all the drugs, or at least one method from each method of administration, one drug for each method of administration has to be covered without a copay. And I think that clarity is actually really helpful to Maine consumers and to Mainers who need to take PrEP. I would counter your suggestion by clarifying perhaps the definition of pre-exposure prophylaxis drug, so that we're talking about the drugs when used as pre-exposure prophylaxis drugs, right? Because that is the provision, the preventative piece of it is what we're driving at here. I think the treatment as well should be a low barrier treatment, because that's going to help us eliminate HIV in our community, as well. But just to stay confined to what we're talking about here, we have been talking about the use of HIV prevention drugs. We're talking about them as prevention drugs when they are part of an antiretroviral therapy, multi-drug therapy. That is a different, concept and not what was intended by this drug, or by this particular piece of legislation. So I guess I would counter your request that we eliminate this section of the bill with a suggestion that we just work on tightening up the language a little bit to make clear that what we're talking about is PrEP used as PrEP, and not Truvada used as one element of, a HIV treatment for someone who has already been, infected with HIV. So I think that's accomplishable, and I think it's within the spirit of the intention of the bill in the first place. It certainly wasn't intended to pull in those other things. So I'll put that out there as a counteroffer, and certainly understand if there needs to be a caucus on that topic. But that's what I would suggest.
Well, we could either caucus it, or we could, we'd certainly be happy to caucus it if you want to have it voted out today, or we could get the language and review it at a future work session.
Do you have a copy of the amendment?
Yes.
Representative Morris? Okay.
Yes.
And if you had, do you anticipate it would take more than 10 to 15 minutes to caucus?
I don't think it would take more than that, no.
Okay, this is probably our last bill today, is that correct? No, I'm sorry.
No, we have one more.
One more, okay, and it's 3:50. We can I think last a little longer, can't we, everybody?
Yeah.
Yes. So I'm going to suggest that we do go ahead and let you guys caucus for 10 to 15 minutes. Come back in 15. Do you have any further questions for Colleen before you go caucus? She was taking some notes on what Senator Sanborn was saying about specifying in that section.
No, I don't think we do. No, I think we're good for now. And so I'll either give her a call or something on if need be.
Okay, so I think we're not going to caucus, or do Democrats want to caucus? No, we're not going to caucus, so we'll take a 15-minute break. And see you guys back here at 3:08.
4:08.
Oh, I'm sorry,
Yep.
4:08. Yes, you're right.
Okay.
All right.
Yep.
Denise or Heather, quick question, if we're not going to caucus, did anything that Heather just say change what is in the current, the last amendment?
It would mean that the language would be a little more specific.
About which part of it? I mean, it doesn't change anything it says. It just says it more in a more specified manner.
Yes.
Okay, great, super. Okay, I'm going to go read it over again in detail.
Okay. Thank you. I'm just going to go refill my water bottle while we wait for our colleagues.
Okey-doke.
Just to let everyone know, our colleagues just let me know they think there'll be about another 5 minutes. So if you want to go do something for 5 minutes, that's fine.
Okay, we're back.
Great. That's terrific. Thank you. Good. Okay. Could all the members of the committee who are present come back online to join us, and we'll get going again on this work session? All right. So I guess what we need now is a motion. Yes.
We
Yes.
we did have some changes we discussed. We wanted to discuss.
Oh, I'm sorry. Okay.
Yep. Sorry.
That's
So
all right.
this is what we discussed and what we would want. We want the bill to align with the ACA language on contraceptive as much as possible, which is what the intent of this with the federal government offering this. So these are what we want to make sure that somewhere under the definitions that there's clarification that the PrEP is going to be used as a preventative. Under Section 4, under 2, coverage required under paragraph A, we want removal of any references to methods of administration and just have it that the Federal Food and Drug Administration has approved one or more HIV prevention drugs, that a carrier is not required to cover all approved drugs as long as they cover one drug with no cost out of pocket. And then under number 3, the same thing, taking out any mention to methods of authorization. Methods of administration. The same issue there. And then under number 4, we want anything, we would like to see language that says to the extent, that clarifies this is to the extent that it is a preventative service. I think the issue on the methods of administration is there is new injections coming out potentially, and we don't know how much those are going to cost in future years. And obviously, if the federal government is offering it, is allowing it to be offered, that's one thing, but we don't want to be out ahead here in Maine. We prefer to be aligned with the ACA requirements that are in the federal guidelines as much as possible.
So you don't want to be the first state in the country to actually eliminate AIDS?
I think that it would be impossible for one state to completely eliminate AIDS because people move around, people can move all the time. So I don't know that you're actually completely eliminating it if one state, I don't think you can ever say you're going to have no cases or new cases in a state. I don't think that that is what I don't think that that's going to, by us being more, it's going to eliminate AIDS in Maine.
Okay, thank you. Thank you, Representative Morris. And Senator Sanborn?
Thanks, Representative Tepler. So just to respond to the comment that you started off with, which was aligning it as closely as possible with the way that contraceptives are treated under the Affordable Care Act, that's actually exactly what the language of my amendment does. Under the Affordable Care Act, all commercial plans are required to cover with no out-of-pocket cost at least one under each of 14 categories of methods of administering birth control. And so those range from sterilization, which is pretty expensive, but only one time, to injectables. There's actually 2 different types. Implantables and injectables are 2 different methods of administration, as well as oral contraceptives, and a number of other things as well on the list, as you can imagine, since I said there were 14. And they all vary in price, and they also vary very much in terms of what they're indicated for and what their public health implications are for the people who use them. And there's a really perfect analogy in contraceptives to what we have coming down the line for us with PrEP. And here's why we should be the leader in that. Oral contraceptives are really hard to adhere to for some women. And those women have accidental pregnancies sometimes as a result. And so those women's doctors might well consult with them and suggest that Depo-Provera, which is a shot or an implant, is a much better means of contraceptive for that woman. And that's a decision that should be made in consultation with her doctor. And that's why the ACA acknowledges that there are 14 different methods of administering contraceptives, and that something out of each one of them needs to be covered without prior authorization or step therapy. We're about to hit the same situation with PrEP, as you know, which is that there is an injectable in the pipeline. And for some individuals who are eligible for PrEP, that shot is going to be the reason that they do not get infected by HIV, because adherence to a daily pill is a very different ask of someone than a long-acting injectable. And so while we don't know what the cost of that is, we do know what the public health implication of it will be. And so I absolutely want us to be the leader on HIV eradication. And we're actually out ahead already. Maine has very good HIV suppression, and this is going to add to it. It's going to be a policy leadership position, but it is absolutely in line with the contraceptives mandate that the FDA has clarified. They had to clarify it because it's not in the ACA statute itself, but it is in the regulations that implement the ACA. And we're gonna go forward in that same manner, in my view, and for similar reasons. Rather than allowing insurance companies to insert themselves in between patients who need PrEP and their doctors with regard to whether this critical medicine will be available to them or not. So that's where I come down on that. I'm fine with indicating the use of it as a preventative, which was what we talked about before we broke. But I'm not going to vote for the amendment if it, for the motion if it includes that further limitation. So I just wanted to be clear, and I'm pretty passionate about this particular issue, as you can tell.
Representative Quint and Representative Morris, I see you both would like to speak, but I'd really like to get a motion on the table before we go on with further discussion. So can you hold on just for a minute while I take a motion from Senator Brenner? Senator Brenner?
I'll make a motion to pass as amended with Heather's amendment and the small language change from Representative Morris that Senator Sanborn approves. No. Yes.
I would recommend that we not add that language change unless it's going to make for a unanimous report. I think the bill is stronger without it.
Okay, let's keep it out.
Okay, so the motion, it's getting late in the day, from Senator Brenner is ought to pass as amended by Senator Sanborn's amendment that we got and Colleen discussed with us. And I saw a second from Heidi Brooks, Representative Brooks. Yes, but Senator Sanborn, are you clarifying the motion? Yeah. Okay, please go ahead.
So just to clarify, there were a few technical language changes from the Board of Pharmacy as well that I intend to incorporate as well, as Colleen described.
Is that, Senator Brenner, that's part of your motion as well? Yes, and Representative Brooks, you're comfortable as well? Okay, good. Now we have a motion on the table and we'll continue discussion. So Representative Quint, please go ahead. You're muted.
Yeah. Yes, I noticed that. Thank you so much. The issue that I'm having is right now the Act does not take into account the new therapies coming forward. And we are now allowing people to go to the pharmacy for this. And so you have people that will hear that this is covered, because remember, only 23% of people will be covered by this, only the people who have insurance. And so they will be going now to their pharmacist demanding something that their pharmacy will not give them because it's covered under the Affordable Care Act. In a situation like this where you have new drugs coming out, I just really feel it needs to be aligned with the Affordable Care Act because that's where the majority of the payments will be coming from. And also the group that is more involved by this, they will be getting the wrong information. They will be thinking it's covered for them when it's actually not. So I'm from a different group of view, not necessarily the insurers, but I have seen before where people are expecting things to be covered because they've heard that it's covered and only the private insurance is covering this. We can't mandate for the Medicare and Medicaid. That has to come federally. And so for me, I would rather have it stay aligned with what the federal government is having and have no, obviously if the federal government changes that or adds something on taking a look at that, obviously we would be mandated and then there would be no conflict whatsoever. But that's where I'm coming from with this. I just think that it's confusing. So that's my take on it.
Okay. Thank you, Representative Quint. And Representative Morris, you put down your hand. Do you still want to say something?
Tracy, sorry, pardon me. Thank you, Madam Chair. Representative Quint, I think articulated my position very well.
All right. Thank you, Representative Morris. And Senator Brenner, go ahead.
Thank you, Madam Chair. I think that we have lots of things that we manage in our committee for the private health insurance community that we don't see we don't always align with the federal government or with the ACA or with Medicare or with Medicaid. And this will just be one of them. And if people, I mean, we all have different kinds of plans. And unless we had a one size fits all plan, it's always going to be different when people show up at the pharmacy in terms of the message that they're getting. It's just the system that we have. It's complex. It doesn't always make sense, but our role, I see it as making sure we can manage a public health as best we can. So I don't see a conflict with not having it covered by the ACA. We want to be on a leader.
I just want to remind the committee that it is now 4:30 and we still have one more bill to do. And so with that, I will turn to Representative Arford, who's next in the queue to say something, but ask everyone to please keep brevity in mind.
Thank you, Madam Chair. Very quickly, I do think that with this bill over time, we can eradicate the disease of HIV from our state, because anybody who crosses the border, if they believe they've been exposed or they've contracted this disease, will be able to go to a pharmacy and the way we've written this law and access at least a 60-day supply of this drug. And with that knowledge, we actually will be able to stop the evolution of this drug or the continuation of this drug within our borders. So I just wanted to say that. And then the second thing, I am going to be supporting this, but I do have a concern about that we have now added onto the authority of the pharmacist, the ability to prescribe these drugs, which they, as far as I understand, they have not had that authority. They've had the authority to dispense, and we gave them the authority with the previous bill, I think it's 603, to administer. And now they have the authority to prescribe. And I just want to point that out and say, I will support the bill, but that is of concern to me in terms of how it's going to affect future legislation, not this legislation.
Thank you, Representative Arford. And Senator Sanborn. Well, before you go, Senator Sanborn, I think I'm going to turn to Representative Brooks, since she hasn't said anything yet, and we'll let her talk, and then I'll turn back to you.
Yes, I'll do my best to be brief, but I really believe this is critical legislation. The compliance with the different methods could be greatly improved, therefore save lives. And I remember in the 80s when this first outbreak happened, and it was devastating, and also treating people that have HIV in the advanced AIDS stages is really heartbreaking. So I would hope that just like we've eradicated polio and smallpox, it's got to start somewhere, and I'd like it to be made.
Thank you. And now I'm Senator Sanborn.
Thanks. I think there's a little bit of confusion, and I was hoping that I could just try and untangle it a little bit. Not that I think I might really change anyone's mind, but the moment that another drug is approved, and the moment, frankly, that the generic came on the market, it fell within the task force recommendations, because the task force recommendations are very broad. I mean, they're specific in that they say HIV pre-exposure prophylaxis medicine is a preventative service under the definition of the ACA. That's what the task force has said. It's not specific to a particular medicine. It is very specific to a particular definition, which is the definition in the bill. And so any new medicines that get added to that definition are, at the moment that they go on sale, covered, I think, within the meaning of what Representative Quint and Representative Morris have been trying to convey within the federal law. So we're not out of alignment with the federal law. What we're doing here instead is trying to make clear how medical management, how prior authorization should be used in Maine, and how it shouldn't be. And it shouldn't be used, in my view, to put a barrier to access for people who are going to need injectable PrEP once that is available. But it is absolutely within the spirit and the meaning, frankly, of the federal regulations that force Maine health plans to cover preventative care once the task force has deemed something to be an A or B rated recommendation. So I hope that helps to clarify a little tiny bit. You know, the moment Descovy or the generic was invented and put on the market, you know, it was part of those recommendations, and that will be the truth for the injectables as well.
Okay, Representative Morris, we're going to let you have the last word before we close down the discussion and have a vote. Please go ahead.
Yes, thank you, Madam Chair. I just wanted to make some clarifying points of my own. Number one, to Representative Arford's point, we're not proposing taking away Section 5. Everything you mentioned about people being able to come into Maine and getting the inject and going to the pharmacy, that we're leaving in the bill. We're good with that piece. To the other point that Senator Sanborn made, I think that brings us back to our original point that we made earlier, is that if this is part of the task force, why do we need Section 4 at all? We can easily do the bill and you're still getting Section 5, which I think is the really important section of this bill, ensuring people can go to the pharmacy without a prescription. And I think that as far as I don't see the need to include Section 4 at all. Frankly, we're willing to do this to make these arrangements. But I think the issue with having Maine be an outlier is, as Representative Quint said, it falls on the 20-something% of people that have a plan that may not require this drug, and they're going to be the ones that are going to have to pay extra through their plan. And so I think, you know, it's good to cover it as is right now. And if in a year the task force says you have to cover some new drug or some injectable, then they'll have to do it under the federal law anyway. So I guess it's just sort of, why does Maine need to be out of step for those 23% of people with the ACA?
Okay, Senator Sanborn, I guess my feeling is at this point, I'm not sure that any response is going to change anyone's vote.
Yeah, I think that's fair, Representative Tepler. I just wanted to say this is about prior authorization on step therapy and where it's allowed and where it's not. So that's putting guardrails, and that is what this is really about. So I'll just leave it at that.
Okay, so we have a motion and a second. I'm going to ask the clerk to call the roll. The motion is ought to pass as amended by Senator Sanborn's amendment with some technical changes from the Board of Pharmacy. And take it away, Christian.
Representative Quinn. I'm sorry, I think you.
No.
Representative Quint, no. Representative Connor. Representative Connor is absent. Representative Blyer. Representative, oh, no, I'm sorry.
No.
Representative Blyer, no. Representative Morris.
No.
Representative Morris, no. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Melarano.
Yes.
Representative Melarano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. 2, 3, 4, 5, 6, 7, 8, yes. 3, no, 2 absent. And I'll turn it over to Colleen to clarify the detail of the minority report.
Yes, please.
Yes.
What would you
ought
like
to
to do
pass.
with section 4? Yeah.
Just remove it.
Okay.
Yeah, I think that makes it easier.
Thank you. But otherwise the same.
Say that again?
Otherwise the same. As,
Yeah, otherwise the
other
same.
reports. Okay, great. Thank you.
Well, we may, I'm getting text that maybe we might want to, the issue that that we just discussed. I guess I'm getting some texts suggesting otherwise from my colleagues in the caucus.
So just as long, I mean, if you would be this, I don't know. I guess if you just articulate that you want to have changes to section 4, I mean, that would be enough as we discussed.
Yeah.
I think that's enough for my purposes.
Okay. I think
but
so.
otherwise it'd be the same. Okay.
Yeah. Yeah.
Can I just clarify? So you're accepting the question of administration for the other sections of the bill?
Yes, absolutely.
Okay.
Yeah, I mean, the issue was not how it was being, it's what's got to be covered by insurance. That's the issue. It's how it's going to be paid for.
All right.
That was the concern.
Okay, thank you. All right, so moving on, Senator Sanborn, do you want to take the gavel back or you want me to keep going?
Sure, I'm happy to. Okay, so we have one more bill to do today. Let me try and get to a page that shows me the bill number. Oh, my apologies, folks. I have a lot of tabs open right now. Oh, that's not it.
No, it's
oh, there it is. Yeah. 1003 is an act to improve outcomes for persons with limb loss. Thank you for the layup there, Representative Matheson. This bill we have not had a work session on yet. So Colleen, I'm going to have you bring up your mandate chart again and just walk us through the issues.
Sure. So LD, let's see, is this big enough for everybody to see? I can try to enlarge it a little bit more. Might be too big, but LD 1003 is an act to improve outcomes for persons with limb loss, as Senator Sanborn said. What it does is it amends requirements in existing law that do provide for coverage of prosthetic devices to clarify that coverage must be provided by carriers for the prosthetic device determined by the enrollee's provider to adequately meet the recreational needs of an enrollee, as well as the medical needs of an enrollee. And as it's drafted, it applies to policies and contracts issued on or renewed on or after January 1 of 2022. As I mentioned, the current law does have requirements in statute that mandate coverage for medically necessary prosthetic devices determined by the provider to adequately meet the medical needs. There is a specific language in the current law that states that prosthetic devices designed exclusively for athletic purposes are not required to be covered. So LD 1003 removes that provision and then adds some specific language requiring coverage for a prosthetic that would meet recreational needs of an enrollee. This is, since it does amend an existing mandated benefit, I think it does fall in the category of proposals that would be subject to review and approval by the Bureau of Insurance, unless the legislature takes action to amend it or exempt it from that review and evaluation. There may be some potential cost to both health insurance carriers, but also potential costs to the state, both in defraying any costs of additional benefits beyond the essential health benefits package, and the financial impact that there might be increased costs to the state employee health plan. We have specific language that governs the benefits that must be provided under the state employee health plan and requires that plan to comply with any mandated benefits in Title 24A. As I mentioned, the existing law does have a provision requiring coverage of prosthetic devices that are medically necessary. And the Bureau of Insurance does maintain sort of cumulative estimates of the maximum cost of existing requirements as a percentage of premium. And in the most recent study or review that the Bureau did on a different proposal, they, as part of that review, they include their estimate for the maximum cost of a particular mandate. And the maximum cost that they've estimated for the existing provision for coverage of prosthetic devices is 0.03% to 0.08% as a percentage of health insurance premium. And that distinction or that range goes to whether or not it's an individual or a small group plan or group plan. You did have some additional information that the Maine Association of Health Plans provided by email that Christian sent to you in response to some of the committee's questions about LD 1003. You also have some folks in the attendee room who could answer some of your specific questions about prosthetics if you have them. The last thing I would mention, I guess, if the committee is inclined to think about asking the Bureau of Insurance to do a mandate review with regard to this proposal, given the time that the Bureau of Insurance requires to do the review, which is really a minimum of 8 weeks. I think if the committee wants to refer or is considering referring LD 1003 to the Bureau of Insurance, that review would likely be conducted over the interim. So you might be thinking about both requesting a review by the Bureau and secondly, asking permission to carry this bill over to the second regular session. I'll stop there and I'm happy to answer any questions you might have. I can also pull up that information that came in if anybody's interested in that as well.
Thanks, Colleen. All right. In the interest of it being almost 5 o'clock, we had a really lengthy conversation about this particular bill. And so I wanted to make a couple of suggestions. I think the question here, well, first I have a question, Colleen. Isn't there an exception to the need to pay for the expansion beyond the EHB when it's an existing mandate that's being edited?
There are some protections which there are some potential protections about the defraying of the state's costs in that situation. I guess I would also note that to my knowledge, the federal government has not required any state to defray any cost of any additional mandates pursuant to the ACA. So that's also a consideration for the committee in moving forward about that. There could be, so if you're thinking about potential financial costs if this moves forward, that's one factor, I guess I would say. I don't know, and the fiscal office was not able to get any sort of preliminary information from the state employee health plan, for instance, for today's work session about what, if any, costs might be associated with this if it moves forward. But I would note that the information you received from the Maine Association of Health Plans, in terms of looking at their membership, noted that it would be the folks who in Maine and they're covered under their health plans. I think it was less than 1% or 1% of a potential population. So that will also affect the cost of this.
Thanks. So I wanted to propose, so I'm interested in sending this to mandate study, but I don't want to send it with the words as they are right now, because I'm concerned that they aren't specific enough to get a good mandate review. And so we had a pretty long conversation about maybe defining what recreation we were talking about. And I think one suggestion that we had come to was running, biking, and swimming being the 3 types of recreation that recreation is meant to encompass. And so adding a recreation definition, and then I had notes here, hang on. And then something like requiring one additional device or attachment that facilitates the recreational needs of the enrollee, or something to that effect. And so I guess I would sort of throw that language out there for discussion by the committee, but also potentially if there are prosthetists or experts in this sort of thing in the committee room that could help us work through the language, that might be a helpful route forward as well. Representative Matheson, go ahead.
We also had discussed limiting it to pediatric too.
We did. I think we decided not to do that, but I'm certainly open to having that conversation as another layer of this as well. Representative Tepler.
Thank you, Senator. I want to express concern in the limitation that you described. I'm sorry I wasn't able to be in the caucus discussion about this bill, but to me, one of the most important and touching parts of the story was about the children who were unable to run and kick a ball. And I wonder if that's fully captured by the 3 things that you talked about. And that is probably something we can ask a prosthetist. And I do think there is a prosthetist in the waiting room, or was. I don't know if he or she is still there.
It looks like Shelley Cool works at Hanger Prosthetics. I think so. Perhaps that person. I'm not sure who Jordan Simpson is. We could have one of those folks. If there's someone in the waiting room who can answer the question that we just raised about kicking a ball, and sort of how do we capture that within the language that we're going to be asking for mandate study on, please raise your hand. Let's bring Jordan Simpson and Shelley Cool both in. Welcome. Oh, right. I remember you now. We have met you before as well. I didn't remember your name, but I remember your face. Thank you for joining us again.
Thank you. And I'm fine with having Shelley go first if she's able to, since she has more of that medical health expertise.
Sure. Shelley, are you able to turn on your video?
Yes, I'm trying here. Can you hear me?
We can. You can go ahead without the video. That's fine.
Okay, sorry. I've gone from my computer to my phone to my iPad.
Sure.
I had to move through my day here.
Understandable.
So, hi.
Thank you. Hi, everyone. My name is Shelley. I'm actually not a prosthetist. I'm a physical therapist, but I do work at an orthotic and prosthetic company and have worked with individuals in Maine with prosthetics for the past 7 years or so. So I'm fairly familiar with the devices from a physical therapy, mobility perspective, as well as working on the O&P side. Just want to clarify, I'm not a prosthetist. So some of the technical information, I'm, more at a different level, so to speak.
So I think the question was about, we're trying to sort of zero in on how to get our arms around recreational so that it's defined, so that when we ask the carriers to do an analysis, a financial analysis of how much this is going to cost, they're able to sort of have a universe to play with. So I guess the question, we came up with a definition of recreational needs as running, biking, and swimming, thinking that doesn't cover everything, but that covers sort of the big major activities that one might think of as recreational needs. So then the question was raised whether that even makes it so that your leg doesn't fly off when you kick a ball. So I guess that's sort of the question, as poorly articulated as it might be.
No, that makes sense. I think the running piece certainly helps to encompass the kicking. Thinking of a pediatric client kicking a ball, typically that is accompanied by, some sort of increase in their speed, running, jumping, that type of thing. So I think that language would be fairly inclusive. Again, I don't know, is there any thought to lower extremity versus upper extremity? Because that definition of recreation doesn't really apply to the upper extremity population. Thinking about, you had mentioned about a prosthesis or an attachment, thinking about somebody playing, tennis or weightlifting, or, going to the gym, a prosthesis that allows them to weight bear through the residual limb for somebody with an upper extremity amputation certainly requires a different adaptation than typical bilateral manual tasks. So that's something sort of separate from the lower extremity amputation.
Okay. That's an important addition to our thinking, our discussion. Ms. Simpson, do you have anything to add?
Yeah, I think it is one of those things that is tricky to put into just kind of one set definition, because depending on your level of amputation, where it is on your body, and also the amount, like I have fingers as well, and then my other foot was clubbed when I was born. So it's going to look different for every person, and also depending on what that person's interests are. Dancing, especially for older adults who've experienced amputations, that's pretty big in terms of their recreation. So in a sense, I almost lean towards leaving that open so that the individual and their provider can really hash that out together.
Representative Brooks, go ahead.
Yes, I had a question about, have you seen any patients that have had adverse medical effects from not having a particular type of prosthesis? Like, is there any sort of breakdown at where the junction of the limb and the prosthesis meet, if there's any sort of risk of breakdown or infection or something like this? I'm asking because I don't really know for sure. If it's not there.
Is that a question for Ms. Cool?
Either one, whoever feels they're more able to answer it.
I can make a couple of comments there. Certainly, the ability for individuals to participate in recreation, following rehabilitation is an important part of long-term maintenance for folks following amputation. There definitely are studies about health-related quality of life, cost savings for the future when individuals are able to return to recreational activities as part of healthy lifestyles. So certainly there is research and evidence out there to show that the ability for folks to participate in these activities post structured rehabilitation is going to improve lifelong outcomes and reduce healthcare costs overall. And I have definitely seen that in practice. You know, it's one thing to have intense rehabilitation inpatient followed by outpatient, maybe, you know, home health in between, but then they need to have something to do. You know, these prostheses are devices, they're tools, but they have to have a purpose. And activities of daily living, you know, walking, standing, sit to stand, you know, doing your IADLs, don't raise your heart rate, don't build your strength, and all those things that are supportive to that improved health and welfare for the remainder of that individual's life. And not to mention the mental, you know, mental, emotional benefits of activity recreation, that sometimes these folks are limited if they are only have the one prosthesis or one terminal device specifically for home household walking or low-level community walking. And that's a pretty significant distinction in most insurance or most payers' policies.
Thank you.
Representative Tepler.
Thank you, Madam Chair. There we go. It takes a couple of clicks sometimes. I was just looking at an article in the International Society for Prosthetics and Orthotics, and there are a bunch of definitions in there that maybe we could use to be more specific. This particular article is about what they call sport prostheses and prosthetic adaptations for upper and lower limb amputees. And perhaps there's something in an article like this that could help us with definitions, so that we could be as accurate as possible in describing what is. The other possibility that I could suggest is that we recommend that there be coverage for one additional device, or if it's upper and lower device, upper body and lower body device, so that a person could participate in a sport of their choice.
So I'm going to actually suggest that, again, given the time and given where we are in this, and because we think we're going to send this to mandate study, I'm going to suggest that we have some stakeholders work on language, and that we work that we give like a couple of weeks, because I think we've been tabling mandate bills anyway to vote them all at once. So I'm going to suggest that we have some folks who, you know, are prosthetists, are insurance companies, and maybe are individuals with prosthetic needs, to come together and just, you know, suggest if we can wordsmith this a little bit. My concern is this, just to be clear, I want to make sure that that there is some standard. I don't really know what it's supposed to be, but that there's some standard in the statute for what is mandated. And recreational was so vague that it felt like you could arguably say everything was mandated to be covered, even if it cost $1 million and no one had ever used it before. And it was experimental and MIT made it just for you. And I think we don't want to go that far. So I want to try and figure out what the standard is. And I don't have the words or the expertise. And I feel like this is what our caucus was struggling with. So rather than Googling the answer, which is always a good place to start, but I think having the stakeholders try and get together and come up with the words might be a great way of approaching this. So I guess I'll invite Ms. Cool and Ms. Simpson, since you're the ones joining us here, and ask if that seems like something you could spend some time on over the next week or two.
Definitely.
Yes, I'd be happy to participate, and I'm sure I could have some prosthetist intervention, you know, ability to join as well. And I just would like to make one other sort of clarification about the term sport, activity, recreation. And, you know, your point was very valid about being too broad and covering everything. But the the bill definitely does support the use of activity-specific prostheses when medically necessary. So they should only be provided when clinically appropriate, which would somewhat mitigate that concern, I would think. They still would have to be validated in terms of being necessary by a physician versus sort of that experimental, new thing on the market for a top level athlete or something like that. There is some language to help with that. I believe in the way the bill is suggested.
Okay.
Thank you.
Yeah, thanks. Okay. So I think is there any additional conversation on the bill? Anyone else want to weigh in before we table? All right. So with that to table, is there a second? Senator Brenner seconded, and all those in favor of tabling, just put your hand in the window. Okay, it's unanimous of those present. And I think with that, we've reached the end of our list for today. So we'll be updating the committee's work session schedule coming up here. I may do it right now, actually, as soon as we get off of this conversation, just because I keep saying I'm going to do it and then I haven't done it. And so that'll go out by email. And we thank everybody for the hard work this week and enjoy your long weekend. We'll see you on Tuesday. Colleen, Christian, and Denise, should we just jump into another Zoom to work on that now?
Sure.
Yeah, I'll send you the
Great.
link.
Thank
Sounds
you.
good. Thank you.